It is 9 o'clock on the East Coast, so I'm just going to give a few minutes more. I do see some folks still in our waiting room that we're letting in, so give them an opportunity to get settled, get their coffee. It's not very sunny over here on the East Coast, rainy, dreary. I hope some of you have sun.
We have enough sun to share with everyone.
Oh, I'll take it, Kim. Thank you.
If you can take some of the heat, that would be great too.
Oh no, I'm okay with that.
Plenty in Nashville too.
Oh, yes, this weather is very up and down. Give it one more minute.
I'm on this WebEx.
Okay. Well, it is 9:02 a.m. on the East Coast. So good morning, everyone. Welcome, greetings. My name is Leanne White, and I'm the director supporting the primary care and chronic illness project for the spring 22 cycle. So I'm glad to see everyone here. Happy to meet most of you for the first time. This is a newer team for this cycle, so really excited to work with you all this spring. I first want to also thank you for your time and participation. I do understand that it's a significant amount of time and effort to review these measures and prepare for today's review. I'd also like to extend a thank you to our developers for being on the call today. We do recognize that there is significant time and effort that goes into the testing, the preparation of the materials, and the measure submission. So we definitely want to highlight those efforts and thank them for their time as well. And then lastly, I'd like to also share my appreciation for your continued patience and understanding as we continue to meet virtually amid the pandemic. We do understand those challenges that accompany virtual meetings, and we do all look forward to the time where we can convene in person. However, in the meantime, we do appreciate your understanding and thank you for your continued support. So we're going to try to make this as bridge that gap as much as possible and try to make this more of an in-person feel across those miles. So I'm going to open it up and let our esteemed co-chairs. We have Dr. Dale Bratzler and Adam Thompson, and I'd like to offer them the opportunity to provide their welcoming remarks. So Dale, Adam?
Well, I'll start. Just thank you everybody for participation. I was telling earlier that that I had a chance to read through all of the work that you did on the measures beforehand. Really appreciated all the comments that you put into the document. So we should have a very robust conversation today, and appreciate the work you're doing.
Yeah, I echo that. Thank you for all the work, and welcome to our colleagues from the other committees. It is great to have you here as part of our committee family today. Also, I just want to let folks know I will have to drop off around 2:00 p.m. today, so my apologies that I'll miss the sort of end of our meeting, but you will be in Dale's very competent hands. So thank you all.
All right, wonderful. Thank you so much. Okay, so we're going to, with the virtual meetings, we're going to take a pause here to get our slides up on our screen. So if you just bear with us just a moment, we will get our slide deck up. Just a reminder, a couple of reminders. So the meeting invite contains all the materials, the slide deck and the agenda for today. All right, perfect. Thank you so much. Okay, so we will go to the next slide, please. And one more slide. We'll go through housekeeping. Perfect. Thank you so much. So I'm going to take a brief moment to go quickly through a couple of housekeeping reminders. As most of you know, we are using the WebEx platform to host the measure evaluation meeting today. If you're having any technical difficulties, please let our team know. You can go through our chat function with WebEx, so you can chat us directly, or you can email us at our project team inbox, so it's primarycare@qualityforum.org. In the spirit of engagement and of collaboration, we also encourage you to use your video so that we can see each other's faces and bridge some of those virtual gaps. If you're not actively speaking, we do ask that you please place yourself on mute to minimize any background noise and interruptions. To mute and unmute, you just click on the microphone button at the bottom of your screen. We do highly encourage everyone to use the chat box feature and the raise hand feature throughout the meeting today. The NQF staff and the co-chairs will monitor the discussions and highlight comments throughout the call. And there's also an option to speak or chat with people directly through the chat function. So you can go to the whole group using the everyone or directly message someone through the drop-down function. With the raise hand feature, will alert the standing committee, the co-chairs, and NQF staff. And so the raise hand icon will appear in your screen. To raise your hand, just click on the participants list and you'll find your name and you'll see that raise hand icon. To unraise your hand or to lower your hand, you click on that raise hand icon again. If you're on the line and you've dialed in on your phone, to unmute and mute, you do *6. So I just wanted to mention that for the phone participants. Once the meeting begins, our Senior Director of Measurement Science and Application, Dr. Matt Pickering, will conduct roll calls and review disclosures of interest. It is important to note that we are a voting body and therefore we need to establish a quorum to vote on our meeting today. If you need to step away from the call, we do ask that you please send our NQF staff a direct message using chat so that we are aware of the attendance and quorum. Okay, so next slide, please. So it's my pleasure to go ahead and introduce our project team. Again, my name is Leanne White and I'm the director supporting this project. Pictured here is our team manager, Isaac Seichi, our analyst, Tristan Wind, our associate, Matilda Epstein, and then our project manager, Victoria Quinones. We also have additional support staff present on the call to help address any of our questions and provide additional support. Our senior director, Matt Pickering, and our project consultant, Dr. Tarun Amin. Next slide, please. I'll touch on some of the agenda items that we have listed here on our screen and that we'll be covering today. We are going to begin again by conducting that roll call and disclosures of interest. A measured specific disclosure of interest form was sent to each member of the standing committee. We must receive this form to review any potential conflicts of interest. Unfortunately, if we've not received this form from you, you will not be able to participate in the discussions or voting today. If you have an outstanding MSDOI, we will reach out to you directly and send you that form. We do ask that you please fill out that form and send that back to us promptly so that you can participate in the call. After we go through the disclosures of interest, Isaac will provide an overview of the evaluation process and the voting process. Then Tristan will conduct a quick voting test. We did send out an email at approximately 8:30 Eastern time this morning that contains the voting link. If you are unable to find that email, please let our staff know and we can definitely resend that. We are not able to place it in chat. It's only for the standing committee members. So we'll work with you offline to get you that link so we can go through the voting chat. We are using Poll Everywhere, which is our online platform for the voting. After the voting test, I'll briefly introduce our measures under review and then hand the discussions over to our co-chairs to facilitate our discussions. Within that discussion is each criterion and voting on each criterion. We also did want to notify you that NQF has created a designated timeframe for developers to respond to questions and provide clarifications. The co-chairs and staff will collect any questions from the developer during the discussion for each criterion. This does include those questions that are placed in the chat. And then the developers will be given an opportunity to respond to those questions and clarify any information prior to the standing committee vote. The last vote we will have would be the overall recommendation for endorsement of the measure. Following our measure discussion, we will review related and competing measures, and then we will host an opportunity for NQS members and public comments. We will conclude with next steps, and then we will adjourn our call. So next slide, please. Okay, with that, I will hand the baton over to Dr. Matt Pickering, who will conduct roll call and review our disclosures of interest. So Matt?
Thanks, Leanne. Can you hear me okay? Yes, can you hear me? Good. Excellent. Great. Thank you. And we'll go to the next slide. So thank you, everyone, for your time, as Leanne said. As we go through the virtual meetings, especially these all-day type of meetings, we understand it's a lot to go through in a virtual environment. So we do appreciate your time and always your attention to our work. Today we'll combine introductions with disclosures of interest. So as Leanne mentioned, you received 2 disclosures of interest forms. One is for our annual disclosures of interest. It goes out every year to everyone. And the other is really specific to the measures that we'll be reviewing this cycle. So in those forms, we've asked a number of questions about your professional activities. And today we'll ask you to verbally disclose any of that information provided on those forms. And if you believe you have any potential conflict, please state so as well. We're especially interested in any grants, research, and consulting related to this committee's work. And just a few reminders, you sit on this group as an individual. You do not represent the interests of your employer or anyone who may have nominated you for this committee. We're interested in your disclosures of any paid or unpaid activities that are relevant to the work in front of you. And finally, just because you disclose does not mean you have a potential conflict of interest. We do verbal disclosures in the spirit of openness and transparency. Now we'll go around this virtual table, starting with our committee co-chairs, and I'll call your name. So please then state your name, what organization you are with, and if you have anything to disclose. If you do not have any disclosures, please just state that I have nothing to disclose to keep us moving along. If you experience trouble unmuting yourself, please raise your hand so that our staff can assist you with that. So as I go down the names, please, I apologize if I mispronounce your name in any way. I do apologize about that. But again, we'll start at the very top. So Dale Bratzler.
Yeah, Dale Bratzler, University of Oklahoma. I am here and I have nothing to disclose.
Great, thank you, Dale. Adam Thompson.
Adam Thompson, here with the Northeast Caribbean AIDS Education and Training Center. And I do consulting work for UCSF, but have not worked with this particular measure in any way.
Thank you, Adam. And then Ann Kearns.
Yes, I'm here, Ann Kearns. I'm at the Mayo Clinic in Rochester. I have nothing to disclose.
Thank you, Ann and Kearns. Apologies about that. Anna McAllister. Anna McAllister. Okay. Moving to the next, Carlos Bagley. Carlos Bagley. Okay. Grace Lee.
Hi, I'm with the Virginia Mason Medical Center, and I have nothing to disclose.
All right. And Grace, I think we are potentially missing the MSDOI, or the Measure Specific Disclosure of Interest form from you. So the team will be sending it out to you. So please keep an eye out in your email. In order for us to have you participate in the voting, we'll have to have that submitted from you. But you've verbally stated you have nothing to disclose. We just need to have that in the form. So we'll be sending that to you. Thanks, Grace. And James Mitchell Harris.
Hi, Mitch Harris. I work at the Children's Hospital Association. A number of years ago, I did some work with Q-Metric of the University of Michigan, who does have a measure up for a maintenance review today, but it's been over 5 years.
Okay, great. Thank you, Mitch. Appreciate that. And so being over that 5-year limit, that wouldn't require any of that recusal. So thank you. James Rosenzweig. Apologies about that. James, are you on? Okay. Kim Elliott.
I think he's unable. I think he's trying to get off mute.
Oh, James, are you there?
He's waving at us. It looks like we gotta get him off mute.
So James, we'll circle back to you, see if we can try to get you off mute. Thanks, Adam, for pointing that out. We'll come back to James. Kim Elliott?
Hi, Kim Elliott with Health Services Advisory Group, and I have nothing to disclose.
Great, thanks, Kim. Lindsay Botsford?
Good morning.
Lindsay, yep, go ahead.
Yeah, Lindsay Botsford, family physician in Houston with One Medical.
And do you have anything to disclose, Lindsay?
Nothing to disclose.
Okay, thank you. Robert Bailey.
Hi, good morning. Bob Bailey, Janssen Scientific Affairs, and I'm a stockholder of Johnson & Johnson.
Great, thank you, Bob. Starlin Hayden Greeting.
Excellent. Yes, it looks like grading, but it's pronounced greeting. I am a pharmacoepidemiologist, health economist. I have my own consulting practice, SHG Clinical Consulting. I consult with the Illinois Pharmacists Association and other pharmacy associations, but what I probably need to disclose is for 23 years, I was the Director of Quality Assurance for Medicaid, 50% feds and 50% Illinois. I'm still on retainer to be on their advisory panel, so only for their patient review. But I thought that since we're talking about California Medicaid data, I felt that you guys needed to know that I had 22 years of experience of looking at Medicaid data. So anyway, but that's the only thing I have to disclose. Thank you.
Well, thank you, Starlin, for disclosing that. It shouldn't be an issue with any work we're doing as far as any recusals for you, so thank you for disclosing that. And good to talk with you again, Starlin. It's been a while.
Yeah.
Thank you very much. William Curry.
Hi, I'm Bill Curry. I'm a family physician at Penn State College of Medicine in Hershey, Pennsylvania. The only thing I need to add is that recently we were awarded an NCI grant for lung cancer screening in primary care that will start 1 July.
Great. Thank you very much for disclosing that. And then William Glom, is it? Glom?
I'm Brendel Glom, Senior Medical Director for Superior Health Plan. I oversee value-based contracting and our quality programming. I have nothing to disclose. Great. Thank you so much. And before going to our surgery standing committee colleagues, I'm just going to circle back to James. James, are you be able to get off mute?
Yes, I'm Jamie Rosenzweig. I'm an endocrinologist with Hebrew Senior Life and with the Endocrine Society, and I have nothing to disclose except that I was involved in research, involved in developing measures that we were discussing 20 years ago.
Great. Thank you so much, James, for the disclosure. Appreciate you being able to get off mute. Okay, so just checking in again, do we have Anna McCollister or Carlos Bagley on the line? Okay, so I'm going to go to our surgery standing committee members. So welcome and thank you very much for your participation in today's proceedings. What I have listed here on the slide, I'll just go down the list, and the same applies to you all, as well as just the name, your affiliation as far as your organization, and also any disclosures you'd like to list. So Vilma Joseph.
Hi, yes, Vilma Joseph. I work at Montefiore Medical Center, Albert Einstein College of Medicine, and I am associated with the American Society of Anesthesiologists, and I have nothing to disclose.
Thank you so much, Vilma. And Richard, and I apologize about this, D'Agostino?
Yes, Richard D'Agostino. Hi, I'm a cardiac surgeon at Leahy Hospital and Medical Center. I have nothing to disclose related to the measures we're discussing today. I am a member on the Adult Cardiac Surgery Database Task Force for STS, and I do participate in a working group that looks at the results generated by the preoperative beta blocker measure.
Okay, thank you very much for that, Richard, for those disclosures. Miklos Kurtai, is that correct?
Thank you. Good morning, everybody. My name is Miklos Kurtai. I'm a cardiothoracic anesthesiologist at Vanderbilt University Medical Center. I have nothing to disclose with regards to the measures that will be discussed today, but I'm a member of the Society of Thoracic Surgeons Thoracic Quality Improvement Committee. Thank you.
Great, thank you so much. Michael Furstenberg.
Good morning, everybody. My name is Michael Furstenberg. I'm an adult cardiothoracic surgeon. I'm actually in between positions right now, so I prefer, for confidentiality reasons, not to disclose my current employer that I'm working with. I'm a member of the SPS. I've been involved in various committees and consulting work over the past 5 years, but nothing that pertains to any of the topics that we're talking about today.
Great, thank you so much, Michael.
Thank you.
Then lastly, Salvatore Scali. Salvatore Scali. Okay, and just one last time, just Anna McAllister or Carlos Bagley. Okay, so thank you all very much. I'd like to let you know that if you believe that you might have a conflict of interest at any time during the meeting as topics are discussed, please speak up. You may do so in real time during the web meeting, or you can send a message via chat to our chairs or to anyone on the NQF staff. If you believe that a fellow committee member may have a conflict of interest or is behaving in a biased manner, you may point this out during the meeting. Send a message to the chairs or to NQF staff as well. Does anyone have any questions or anything you'd like to discuss based on what any of the disclosures that have been made today? Okay, no, nothing in the chat, no hands raised. Okay, thank you very much. And lastly, as a reminder, NQF is a nonpartisan organization. Out of mutual respect for each other, we kindly encourage that you make an effort to refrain from making comments, innuendos, or humor relating to, for example, race, gender, politics, or topics that otherwise may be considered inappropriate during the meeting. While we encourage discussions that are open, constructive, and collaborative, let's all be mindful of how our language and opinions may be perceived by others. With that, I will turn it back to the team. So thank you all once again very much, and looking forward to the rest of the proceedings.
Wonderful. Thank you so much, Matt. We do appreciate you joining us on the call today. So I'm going to actually turn it over to Isaac Seichi, our team manager, who will present an overview of the evaluation and voting process. So if we can go to the next slide, please. All right, so Isaac.
Can we go to the next slide? So, previous slide. Thank you. I'll be going over the evaluation process that will be followed today. Our standing committee members act as a proxy for the NQF stakeholder membership. They evaluate each measure against each criterion, and with that, indicate the extent to which each criterion is met and the rationale for the rating. They also respond to comments submitted during the public commenting period, make recommendations regarding endorsements of NQF membership, and oversee the portfolio of PCCI measures. Next slide. To go over some ground rules, we would like to emphasize that this is a shared space and there's no rank in the room. We encourage you to remain engaged in the discussion without distractions and hope you're prepared and have already reviewed the measures. Please base your evaluation and recommendations on the measure evaluation criteria and guidance. Keep your comments concise and focused, be cognizant of others, and make space for others to contribute to the conversation. Next slide. In terms of how the discussion will proceed, we'll start with a brief introduction of the measure by the measure developer. The lead discussant will then briefly explain the information provided by the developer on each criterion, followed by a brief summary of the pre-evaluation comments from the committee, emphasizing areas of concern or differences of opinion. The lead discussants will also note preliminary ratings by NQF staff, which is intended to be used as a guide to facilitate discussion. Developers will be available to respond to questions from the standing committee. Afterwards, the full standing committee will discuss, vote on the criterion if needed, and move on to the next criterion. Next slide. The following is a list of our endorsement criteria. 5 areas are outlined here, namely importance to measure and report, which includes evidence and performance gap. Scientific acceptability, which also includes reliability and validity. Please note that the first 2 bullet points are a must-pass criteria. We also have feasibility, usability, and use, and related or competing measures. The use subcriterion is a must-pass for maintenance measures. The next point of discussion is the comparison to related or competing measures, which is a discussion and does not require a vote. That discussion only takes place if the measure is recommended for endorsement. Next slide. So again, these are the criteria the measures are evaluated and voted on. Next slide. If a measure fails on one of the must-pass criteria, there is no further discussion or voting on the subsequent criteria for that measure. The committee's discussion will move on to the next measure if applicable. In our case, we have multiple measures. We will share next steps in the process should we find ourselves in the case where a measure does not pass on a must-pass criteria. If consensus is not reached on a criterion, the discussion will continue to the next criterion, but there ultimately will not be a vote on the overall suitability for endorsement. Next slide. As far as achieving consensus, quorum is 66% of active standing committee members, and that is 13 members for our 19 active standing committee members. We need greater than 60% yes votes to pass a criterion or recommend a measure for endorsement. So yes votes are a total of high and moderate votes. Between 40 to 60% of committee members voting yes will be consensus not reached, and less than 40% voting yes means the criterion does not pass or the measure is not recommended, depending on what we're voting on. The consensus not reached criterion and the vote on overall suitability for endorsement would be postponed to the post-comment meeting. If the measure is not recommended, it will also move on to the public and NQF member comment, but the committee will not re-vote on the measure during the post-comment meeting unless the standing committee decides to reconsider based on submitted comments or if the developer submits a formal reconsideration request. Next slide. As mentioned before, please let us know if you need to step out of the meeting. We need quorum to vote on the measures and at least 50% of the standing committee on the call to continue the discussion. If we lose quorum at any point, we will shift to an offline survey, which will contain the same questions as the live voting platform. In that situation, we will ask that the standing committee submit their votes within 48 hours of receiving the survey and the transcripts of the meeting. If a standing committee member has to leave and we still have quorum, the committee will continue with the vote and the discussion. The standing committee member who left will not have the opportunity to vote on the measure evaluated during their absence. That sums up the process for today's meeting. And at this point, I would like to pause to see if there are any questions.
Isaac, have we done the count? So do we know what our quorum is for today? I know we had a couple of members that couldn't be here.
Yeah, so quorum today is 13 members, and we have 16 standing committee members on the call.
Yeah, very good.
So hearing no other questions, I will turn it over to Tristan for a voting test.
Thank you, Isaac.
And while Tristan is pulling up his slides, again, please let us know if you have not received the link in your email. We'll be happy to work with you to get that. Thank you. Okay, Tristan.
Thank you, Leanne. So good morning, and thank you for attending today's call. We sent a voting link via email. If you have not received that, please let a team member know, and we will be happy to assist. So today's test question is, have you visited the beach? Select A for yes and B for no.
I'm able to, this is Michael Furstenberg. I'm listening on my phone, but I had to step away from my computer for a few minutes. So I'm not going to be able to vote for a little bit, for about 15, 20 minutes, if that's okay.
Michael, that's perfectly fine. And if you also, if you need to directly message the team with a vote, we can also work with you to do that as well.
Thank you, Michael.
Okay.
So for today's purpose for voting, for the test, we will have 15 votes instead of 16.
This is Brendel Glom. I'm sorry, I'm just not getting a response here on the screen. Where?
So using the voting link, so you will be prompted to type your name, and then that will pull up the question.
Sorry about that.
No, you're okay.
Did we lose everybody? You guys still there?
We're here.
Yes, we're still here.
We're still here.
We're just waiting for one more vote. Okay, perfect. We are at 15.
Perfect. So that conducts today's voting test. 53% voted yes, 47% voted no.
In all fairness, it's the beginning of summer, so we all have time to get to the beach. Okay, perfect. All right, thank you, Tristan. Right, so we are going to pull back up our slide deck here to start our measures under review. One moment. The logistics of virtual meetings here. Oh, Victoria, I think you need to share your screen again. Perfect. Okay. So I will go through our measures under review for this cycle. Next slide, please. And just provide a brief overview. So that we received 3 maintenance measures and 1 new measure for the spring 2022 PCCI cycle. The 3 maintenance measures are 0729, optimal diabetes care, 2797, transcranial Doppler ultrasonography screening among children with sickle cell anemia, 3294, STS lobectomy for lung cancer composite score, and the 1 new measure for standing committee review is 3668, follow-up after emergency department visits for asthma. Next slide, please. We did not have any measures go through SMP review this cycle, but we do like to talk about the SMP and their role in the measure review process. The Scientific Methods Panel is a group of researchers, experts, and methodologists in the healthcare quality and quality measurement arena. The panel reviews complex measures and provides comments and concerns to the developer. The developer then has the opportunity to provide further clarification and update their measure submission form before the standing committee evaluation. Again, no measures were reviewed by the SMP for the spring 2022 cycle. Next slide, please. Great, and then next slide, please. So now we have reached the part of our measure evaluation meeting where we begin the consideration of our candidate measures. We'll go to the next slide. So with that, our co-chairs will begin by introducing the measure. The developer will then have the opportunity to provide a 3 to 5 minute overview of their measure. Our lead discussants will introduce the criterion and highlight their main takeaways. Our supporting discussants will respond to the lead discussant and add their insights. During the criterion discussion, the co-chairs and staff will collect those questions for the developer. Once the initial discussion on the criterion is complete, the co-chairs will then ask the developer to respond to questions and then clarify any information. Once the standing committee has completed its discussion, our vote will be taken on the discussed criterion. So our first measure is measure 3668, follow up after emergency department visits for asthma. The measure steward is Albert Einstein College of Medicine, and the developer is UCSF. This is a new measure. The brief measure description, it is a process measure that seeks to capture follow-up after asthma-related emergency department visits for children with asthma after discharge from the emergency department as recommended by NHLBI 2007 guidelines. The measure also assesses the percentage of asthma-related ED visits for children ages 3 to 21 with a follow-up visit with a primary care clinician or an asthma subspecialist within 14 days of discharge from the emergency department within the reporting year for patients who are enrolled in the health plan for 2 consecutive months following the ED visit. So with that, I will pass the baton over to Dr. Dale Bradsler, who will take lead on this discussion. So Dale?
Yeah, thank you, Leanne. So this is a new measure, so we'll be going through a complete evaluation of this particular measure. And I believe we have a representative of the developer here. Is Naomi on the call? Do we have somebody from the developer on the call? I can't see everybody on the. I know it's early in San Francisco. Leanne, do you know if the developer's on the call?
I do not. I have some call-in users. I'm not sure who those are, and I will also look through our inbox to make sure, check those communications.
Well, hearing nobody from the developer at the moment, should we just go ahead and start the conversation? Then if a developer comes on the line or notifies you, we will stop and give them a few minutes to describe the measure. So Anna had notified us that she wouldn't be able to be with us first thing this morning. So I believe Starlin has agreed to be the lead discussant for this particular measure. So Starlin, I'm going to turn the conversation over to you at this point.
Okay, yes. So as what was previously read, it is a new measure, follow-up to emergency department visits for asthma in the ages 3 to 21. It's a process measure. It uses Medicaid claims data, and it's important to note that Medicaid claims data is sometimes very different than commercial insurance claims data. We're trying to make it all the same, but we probably need to make note that it is a Medicaid claims data. And the level of analysis is for a health plan. And so with their evidence, they used a systematic review. One of the authors of the systematic review was part of the review process, part of the team that developed and did the measure. And I'll go right to some of our committee comments. My first question, just because of the hat that I wear, is sometimes California defines eligibility for Medicaid up to 21 years of age, and then they've added up to 26 years of age in this past COVID. So that's important to know. In Illinois, we cut it off at 18. So each state sets their age standards for pediatric care that's being covered under the Medicaid. If they still require Medicaid after the age of 18, they move into the adult phase. So that's a clarification I was looking for. So this process measure the evidence from 2007 National Asthma Education and Prevention Program Guideline for the Diagnosis of Management of Asthma Summary Report. They have a new 2020 report, but the 2020 report dealt mostly with medication updates. I reviewed both of those reports. And the guidelines were, and they state that they were updated, but it didn't impact the course of follow-up. Now, I completely support a follow-up because, as we know, specifically in the Medicaid population, sometimes they don't have a primary care professional, and the emergency room is used as their primary care delivery system. So the evidence is there for that. For the gap in care, they did an excellent review of their performance, but then I in my comments, I did point out that, you know, the 18 to 21-year-old area didn't perform as well as the 3 to 18-year-old groups, and in my personal experience, we have fallout. We lose track of patients after 18, and they may not stay in the Medicaid or any insurance system, or they may switch to a different insurance, or some colleges provide insurance, so forth and so on. But in their data set, they did an excellent job of the lowest decile was 11.7%, and with an N of 9 a health plan. This comes from their systematic review, which was also had high marks for their systematic review that they used for their evidence. Performance in the highest decile was at 43%, and overall performance was 22.1%. The follow-up visits were higher in patients ages 3 to 5, and those who were Asian Pacific Islanders had a higher percentage of follow-up visits compared to those who were Black, Hispanic, and white. Some of that may be the geography. So California has many more people of those diversified cultures. So when you apply this to other populations, you may need that culture shift may happen. Patients with Medicaid fee-for-service had a 10.2% and were less likely to have a follow-up visit compared to those with managed Medicaid, which was 23.9. Now, I need to also let you know that managed Medicaid is required in their contracting across all states to have that follow-up visit. So this is a good performance measure to ensure that that is happening. Do you want me, we need to stop after evidence, right?
Yeah, I think so. I had one question for you, Starlin.
Okay.
I know the guidelines recommend the follow-up, and the performance rates as listed here were quite low. Is there good data on changes in patient outcome?
So I think there is, but this is a Medicaid population, and they mostly referred to their systematic review. I tried to pull some of the articles out of that systematic review that they use to support that, and there is good support. Oddly, or serendipitously, JAMA just published an article yesterday that said a phone call within 2 to 14 days after emergency room visit improved all patient outcomes, no matter if it's asthma or not. So, and in my own personal experience in doing chronic care conditions, they're having follow-up, getting connected to a health professional post their emergency visit, it leads to good outcomes in the evidence. And their systematic review did include many of those articles that support that.
Okay, thank you. So before we go on at this point, I'm going to see, Lindsay, you were the secondary reviewer. Do you have any particular comments on the evidence for this metric?
Yeah, thanks, Dale. Yeah, I think similar to Starlin, they do have a combination of a few small randomized controlled trials and then some observational studies that do confirm the association between follow-up visit and decreased ER utilization in the future. What is a little bit unclear is you don't know what the content of the visit was at follow-up, and was there anything different about the content of the visit? Was there an asthma action plan done, or was this a visit that actually happened to not discuss the asthma but happened in a PCP setting in that time frame? So I think not complete homogeneity in terms of what happens at these visits that reduces it. So it does seem like there's a strong association. It was less clear to me if this was causation or other factors that would encourage or that would enable a patient to have a follow-up visit also decrease the likelihood of future ER utilization. The other thing I think that was a question for the developer, if at some point they join us, is it looks like the 14 days was chosen. In the 2007 NHLBI guidance, the recommendation is that the follow-up happen in 1 to 4 weeks with a PCP or asthma specialist. Now, since those guidelines came out, there have been studies that that anchored on 14 days, which I think supports their choice of 14 days, but I would question that. And then the final question I had was getting towards what this most recent discussion was on, is what type of visit counts. In a world where virtual and phone encounters exist, are those included in the claims, or is this an in-office visit only? And that was potentially short-sighted. Overall, I think, while the number needed to treat feels a little bit high to me, the potential reduction across the population does feel real. I think we'll get into some of the disparities discussion later, but those would be the comments I think about evidence that would be helpful to probe a little bit more.
Yes, and the study was pulled claims from 2015, and so we were, while California is ahead of the game in the telehealth, telemedicine world, we don't know if that was utilized. I know that California Medicaid was part of some demonstration projects in their rural areas to enhance telemedicine for chronic conditions, asthma, COPD, diabetes, and cardiovascular disease. But again, they did not mention any of that. That is just the fact that I know that because I'm in that world, but that would be helpful to know. So I concur.
All right, thank you both. So I'm actually taking notes in case we get the developer on the call so we can summarize those questions. Anyone else on the committee have any comments about evidence? We're going to limit our discussion to evidence at the moment.
Excuse me. Are there how are the follow-up visits documented? If a person, let's say, moves out of the state or something to a different area, and there's a telephone call, is that considered a follow-up?
Yeah, I think that was one of the questions that Starlin and Lindsay both had. Does telehealth phone call follow-up to any of those count? Since this is Medicaid claims, I'm assuming there would have to be some type of encounter documented in claims.
So that goes along with my question. So in the claims data, we have G codes that indicate whether it was audio or telemedicine that go along with that Medicaid claim that could be pulled at the same time when they're doing that their preliminary pull. The other concern I had was looking at patients that had a primary care provider prior to being looked at. So if you don't have a established primary care provider, you'll use the emergency room. So when I did a similar study like this in Illinois, in the Chicago area, and we went through and pulled everybody who had a primary care provider attached to them, and then did the same analysis to see what was happening in the emergency room recidivation visits. So you first need to establish a primary care provider is in place, then you pull that data, then you can look and see what kind of post-data visits happened after the emergency DRG code. The other concern I had is, depending on the state Medicaid, sometimes the state Medicaid grants high Medicaid hospitals blanket money to be the primary care provider in an underserved area, and so you're not going to see those in that data. So in the evidence, it would be nice to kind of get a better idea of the. I mean, I'm not suggesting they give us all the claim codes because that would make us dizzy. But if we could see, if there was a G code, you would know if it was a telehealth follow-up visit, that sort of thing. Anyway.
All right. So I mean, I think we're circling around this. So we have a question or two here for the developer about how this is counted. Starlin, you've raised some issues. I know I read your comments earlier about, does the patient have a pre-existing PCP? Because it is very difficult to maybe get into one if you don't have one pre-existing. So any other comments about evidence, and we'll move to that vote.
Dale, this is Brendel Glom.
Yes.
Pediatric. I'm a pediatric pulmonologist. I guess one of the things that I'm concerned with is again returning to the diagnosis itself. There are in our data, which is pretty significant with 2 million Medicaid members, we've got a lot of, for lack of a better term, overdiagnosis of asthma in the emergency room. First-time wheezers, infants, young toddlers, as an example, with bronchiolitis. Is there a plan within this data analysis to sort that out? This, as an example, a patient may be well known to the PCP for whatever reason, however the patient winds up in the emergency room, has the tag of asthma, but put on that visit, and then they're back to the PCP who knows that knowing this patient knows that this is not an asthmatic patient. Is there a way to filter out some of this? Is there, if it's not really asthma, if the PCP knows the patient well, is there a reason for it? And I'm being, yes, I think there is personally, but is there a reason for having a visit within the 14-day window? I hope I'm clear on that.
Yeah, thank you. Anne, you have your hand up.
Yeah, I'm not sure if my question is relevant to evidence or not, but I'll raise it. And that is, if the ER visit happens in a system different from the primary care, how does the primary care, and maybe I don't know enough about how Medicaid functions to alert a primary care, but in the adult world where I see people and they don't know who their primary care is, or it's a team, and you're trying to alert them because they're not in my system, and then you have such a short window of 14 days to communicate with the primary care to get the appointment set up. It just seems, maybe this is more a feasibility issue and maybe this is not an evidence issue, so tell me to hold it if that's the case.
All right, thank you. Also, I'm going to go to one more person. Dr. Curry, you had your hand up, and then I believe the developers joined us, so we'll break and let them give a brief introduction.
Yeah, thanks, Dale. There is some evidence that in the Medicaid population that a visit with a primary care provider may not impact the ED readmission rate or ED utilization. However, if that's done in a primary care-based asthma specialty clinic, there's been shown some significant reductions in ED utilization. So I guess the question is that from the outcomes, was asked before, does it matter where they get their follow-up? And there might be some evidence that says yes.
All right, thank you. Naomi, I understand that you've joined the call. ECSF?
Hi, yeah, good morning. Apologies, I'm coming from another NIH review committee, and I thought we were starting at 9:55 with the measure, so I apologize for being a little bit late.
Okay. So if you would, we'll go back to the start and let you give the 3 to 5 minute overview of the measure, and then a number of questions have been captured.
Excellent. So this is a measure that is a claims-based measure. It's focusing on particularly pediatric asthma care, which, as many of you know, it's a highly prevalent condition in pediatric patients. It leads to a fair amount of healthcare utilization, as well as missed school days and missed work days for families. The measure itself is looking at for those patients who go to the emergency department for an asthma-related visit, for children ages 3 to 21, the question is whether or not they had a follow-up visit. So the measure assesses whether or not they had a follow-up visit with either a primary care clinician or an asthma subspecialist within 14 days of discharge from the emergency department for patients who are enrolled in the health plan for at least 2 consecutive months following the ED visit. It's an administrative claims-based measure. We tested it in the Medicaid population in California. We also published a paper looking at it in Massachusetts and Vermont data as well, which we didn't include in this particular submission, but that's the sort of evidence behind it, in addition to the fact that it's consistent with NHLBI guidelines for asthma care for pediatric patients.
All right, thank you, Naomi. So I'm going to try to summarize a few of the questions that came up in our discussion of evidence. One thing, because this is an administrative claims-based metric, what about follow-up via telehealth or phone call or other follow-up? How is that handled in the metric?
That is a great question. It's anything that is a claim in the administrative claims-based data. So it's all, it's going to be Medicaid data or commercial claims data. So anything that's a claim is going to be included in the measure, as long as it has the correct ICD code and the provider type is captured by the measure specifications. So it's a great question, because we did our data analysis. We used data that was before the pandemic, and so telehealth is just not going to have been as common a mechanism. So that it really gets to the question of in the brave new world of who's going to be reimbursing for telehealth, whether or not those telehealth visits are actually going to be counted in a claims or not. Right now, the measure specifications do not differentiate between a claim that is telehealth versus a claim that is not telehealth.
All right, thank you. Then another question came up about just diagnostic accuracy. So perhaps the patient has been seeing a primary care physician over time, gets a diagnosis of asthma in the emergency department where there are some concerns about diagnostic accuracy. The family physician or primary care or whoever is taking care of them knows that the kid actually doesn't have asthma, but that diagnosis comes up.
And so the question is whether it would be appropriate for a follow-up visit, like meaning that the PCP might then say, oh, you don't actually have to come back in?
Yes.
I would probably argue that clinically that might not be actually a practice, because if you have a patient who's in the emergency department and is diagnosed with asthma for the first time, you might actually, I would suspect most clinicians would not say, oh, that person shouldn't come in because I know for sure they don't have asthma. I think that would be actually a situation where a primary care clinician would say, oh, that's new. We should make sure that the kid is doing okay. So I understand the concern, but I think that that might not actually be something that happens in practice. And it's also a health plan level measure. So it's a question of it's not the primary care physician who would be then the accountable entity who would then be considered underperforming because it's a health plan measure.
Okay. And then the last one that I've written down here, I thought was very interesting. Have you stratified the measure based on whether the patient had a documented assigned PCP before the event? In other words, somebody who presents for the first time to the ER with a new diagnosis of asthma who doesn't have a pre-established PCP, it may be quite difficult to get in to a PCP within 2 weeks. Have you stratified the data that way?
So we looked at what we termed identifiable asthma versus non-identifiable asthma. And the identifiable asthma is people who had a diagnosis of asthma prior, looking at their 1 year look back period in their claims data. So and we found that it was that the follow-up visit was associated with decreased utilization, subsequent decreased utilization, whether you had identifiable asthma or not identifiable asthma. It tended to be actually a little bit more a stronger association if you didn't have identifiable asthma. I think in part because of the fact that then those patients got connected. If they were connected, then that was actually a good sign, and they were able to then have their asthma managed. And so we did not do a stratification by whether you had a PCP prior or not, but it does look like it's probably associated, that there is some association between people who have had a PCP prior or not, because we also see a pretty long-term effect all the way out to a year of having that follow-up. And so it's probably an indicator not only of that one visit, but actually that you have an established primary care clinician, meaning that you already were able to get into that PCP relatively easily. Therefore, you have that visit, and therefore you probably have a relationship that then leads to ongoing monitoring and treatment of your asthma a little bit more effectively. So I do think there's some signaling, but actually I would say because it's a health plan measure, that's sort of appropriate, that health plans should be helping to facilitate people getting connected to PCPs and and having sort of a primary care environment that they have access to primary care physicians. So,
yeah, thank you for continually reminding us it is at the level of the health plan. That's helpful. Adam, did
This is Brendel. Can I insert a question with regard to that health plan evaluation? Sorry. I'm sorry, Ms. Vardak. I'm a pediatric pulmonologist with Centene Corporation. Given the often lengthy claim submission, how is that dealt with, or is it dealt with within the measure if the follow-up is supposed to occur within this window, but a claim submission, because this is a claims-based measure, is not in an almost instantaneous fashion? How would you suggest then that the plans deal with that lag and their ability to point the patient into their PCP? Second to that, in Texas, all children in Medicaid are required to have a designated PCP. Whether or not they utilize that PCP or not, it's a different story, but they all do have one. So I'm just wondering about the claims lag and then that responsibility to the plan, who may not even know for 14 days, as an example, that such a visit has occurred.
Yeah, a great question. The way that I think about healthcare organization and how a health plan might have a level of control over this would actually not be that that it's on them to call the patient as soon as they go to the emergency room, but actually that it would be something that they would create systems of care where, exactly to your point, where there's sort of a requirement that they be connected to have a PCP, and that there's some ability to access PCP appointments. And that goes to other quality measures like third available appointment in the primary care setting. So I think your point is well taken, but I think the measure wouldn't exist in a vacuum. And in general, we should be moving towards getting better connection to the PCPs or to care after the emergency department visit. I will make one other note, which is Dr. Cabana, who is also he's the measure steward and a measure co-developer, is here with us also. We were in the same NIH review section, actually, so he is coming over from that meeting as well.
Thank you. Adam, have I missed anything?
I think the only lingering question, it was somewhat, I think, even resolved in our committee discussion, but I want to make sure we put it out there, was the difference between the recommendation being follow-up within 1 to 4 weeks and the measure using 14 days, and whether there was any specific reasoning behind that decision.
Yeah, the 14-day window, we thought about different windows: 7-day window, 14-day window, 30-day window. The association was sort of strongest when it was within the 14 days. There aren't enough visits within 7 days to actually be able to get a whole lot of signal, because just your sample sizes are so low. 14 days was with a stronger association of having decreased utilization subsequently compared to a 30-day window.
Thanks.
Thank you. So I think at this point, unless anybody that has things in the chat, I think we've captured all those. We'll go ahead and take a vote on evidence.
So if you just bear with us just a moment, Tristan will bring up his Poll Everywhere screen. And if you just recently joined us, I know we had Carlos join us. Carlos, welcome to the call. We do just need to quickly go over a quick introduction. So if you can please just state your name and your organization and any disclosures that you may have before we proceed to the vote, I'd greatly appreciate it. Carlos, if you're able to come off mute. I will go ahead and unmute you. We will work with Carlos behind the scenes. So, okay, Tristan, go ahead, and if you could pull that up, please.
Thank you, Leanne. So voting is now open for measure 3668 on evidence. The options are A for high, B for moderate, C for low, and D for insufficient. As a reminder, we will be waiting for 17 votes.
Excuse me. I am clicking on the boxes and nothing shows up. Is there? I'm on the wrong screen.
Yeah, don't use the slide that they're showing on the screen. You have to go to the link. Sorry. I tried the slide too the first time, and then I realized I was looking at a slide.
That's a great point. As a reminder, we will be using the same exact link for the duration of this meeting. So again, we will be waiting for 17 votes. Is anyone having difficulty right now? As we're awaiting 2 more votes. If so, please raise your hand or contact a team member in the chat.
James, I see your hand up.
If you are unable to vote using the link, please just message Isaac Seichi, our manager, directly. So if you go to the chat box, you can drop down, find his name, and you can message us privately your vote.
And last call for voting. Okay, it looks like we have received all the votes. Thank you for your patience. So voting, we received 0 votes for high, 14 votes for moderate, 2 votes for low, 0 votes for insufficient. Please provide the team 1 moment to confirm the votes. Therefore, the measure passes on evidence. Thank you. Back to you, Leanne.
All right, so thanks. So if we'll go back to Starlin, and if you'll talk about performance gap.
Okay, so in the performance gap, the lowest decile is 11.7%, and performance in the highest decile was 43%. Overall performance was 22.1%, and the follow-up visits were higher in patients in ages 3 to 5, as we mentioned before, and lowest in patients 18 to 21. Those were, and then I pointed out previously that the cultural differences, Asian and Pacific Islanders had a higher percentage of follow-up visits as compared to those who are Black, Hispanic, and white, and that the fee-for-service Medicaid were less likely to follow up as compared to the Medicaid and the managed care group. Now, the managed care group this is a requirement in most managed Medicaid contracting. So they have a moderate performance gap. And Lindsay, do you want to add anything to that?
No, I mean, I think the evidence highlights a gap, some of it bigger in certain populations, which we can get to in some of the equity conversations later. But certainly the performance, that seems fairly good evidence that it exists.
All right, thank you. So anyone else on the committee have any comments about performance gap? So, Adam, I'm counting on you to keep me honest about hand raising because I don't see those all the time. So if there are no other comments at this point, I think we could go ahead and vote on performance gap.
So voting is now open for measure 3668 on performance gap. The options are A for high, B for moderate, C for low, and D for insufficient. Again, we are waiting for 17 votes.
And while we're voting, I just want to try again to reach out to Carlos Bagley. If you can please come off mute and introduce yourself, your organization, and any disclosures that you may have.
Okay, voting is now closed on performance gap for measure 3668. We received 4 votes for high, 12 votes for moderate, 0 votes for low, and 0 votes for insufficient.
Just a correction, we have one more vote, so we have 13 votes for moderate.
Thank you, Isaac. Please provide the team 1 moment to confirm the votes. Measure passes on performance gap. Thank you. Back to you, Leanne.
All right, thank you. Starlin, if you would go ahead and we'll start talking about scientific acceptability. We'll focus on reliability first.
So the reliability specification, I need to point out that each state Medicaid selects and administers their own program, and it can be different state by state. And so whether for fee-for-service or managed Medicaid, the only thing that is somewhat consistent across all 50 states and territories is the managed Medicaid set of guidelines for them to go into place before the CMS accepts the managed Medicaid profile for a state. So if this goes to use for a health plan, the health plan will have to, so if they're doing a managed Medicaid health plan, they're going to have to assess what their state requirements are. If it goes to commercial, some of the same things. So there's state to state differences, as we all know in this world. The Medicaid data limits the ability to do cross over into a commercial plan to some extent. I still think I still believe this is a useful measure because we don't do enough follow-up with children. But I'm just saying that in my 23 years of Medicaid practice, I was never able to go because I also did the employee health for Illinois, and I couldn't use one set of data to make the commercial insurer people use the same measure of quality. So I just want to bring that up. But their specifications are clear and precise, and they did very well consistently implement that reliability. They had great quartiles and great confidence intervals for their random split half reliability testing, and they were able to compare the fee for service with the managed Medicaid, which was very well done.
All right, Lindsay, do you have any comments?
I think the only other things to build would just calling out that it did look at over 100 plans and had some exclusions for plans with a small number of eligible patients. So seemed to account for issues of plans that might be skewed by just having a smaller population.
Right.
So they did account for some thoughtful things in the testing. So again, maybe some concerns to talk about later, but in reliability, I think no major concerns noted here.
All right, thank you, Lindsay. Any other committee members that have comments about reliability? All right, hearing none, I think we can move to the vote on reliability.
Voting is now open for measure 3668 on reliability. The options are A for high, B for moderate, C for low, and D for insufficient. Again, we will be waiting for 17 votes. Voting is now closed for measure 3668 on reliability. There were 6 votes for high, 9 votes for moderate, 1 vote for low, and 0 votes for insufficient. Please give the team a moment to confirm the votes. Therefore, the measure passes on reliability. Back to the co-chairs. Thank you.
Thank you, Starlin. I'll turn it back over to you to just.
I'm sorry, I just need to make a correction to the record, Dale, real quick. So we do need to correct the record for GAP. We did have someone vote twice. So we just need to make sure for the record, we have for the results on performance GAP, we had 4 votes for high and 12 votes for moderate. The GAP criterion still passes with 16 votes for moderate and high, but we went down to 12 from 13 on moderate. So just need to make that quick correction. Thank you.
All right, thanks. Thanks for keeping us honest here, Leanne. All right, Starlin, talk about validity.
All right, so they did 2 validity testing. They did a patient encounter level, and they did it at the, also tested at the accountable entity level. And their model was adjusted for average age during the index year, gender, chronic disease status, insurance type evidence, and making sure that the evidence was that they had asthma. They used a strata post estimation margins, which shows up with patients with a follow-up within their 14-day window and a 365 in that 65 days of asthma-related ED visits. And they showed the lower rates of subsequent asthma-related utilization as 5.7% with a good confidence interval, and 25 and also 5.7% to 25% as compared to no follow-up, which was 6.4% to 28.3%. The validity on the accountable entity level, they assess the relationship between performance on the measure and the eligible patients in their repeat utilization. They had a beta coefficient of negative 0.19 with a p-value less than 0.001 for 60-day revisits. And for each 1% increase in follow-up visits, there was a decrease of 0.2% in a 60-day emergency room revisit. And the staff rated this as moderate for validity.
All right, thank you, Starlin. Lindsay, you have comments?
Yeah, I did find this part interesting, and that, you know, it sounds like some of the previous literature 20 years ago looking at the correlation between ER utilization and PCP visits actually didn't show an improvement, or if anything, showed a paradoxical increase in utilization, perhaps due to a bias in selection. But I think it sounds like the results of this testing are currently in press. I don't know if there's any updates on that. So also, it sounds like the claim sets that were used were more than one state. I think also Massachusetts and Vermont. So we're not just looking at California data in looking at whether there are correlations. So did seem to be statistical significance in those different populations, showing you know, performance on the quality measure. So no comments or concerns. I think it did look like, again, a thoughtful approach to confirming the association in a variety of data sets, especially in light of previous evidence that would suggest not a benefit to this process measure.
All right, thank you, Lindsay. Any other committee members that have comments about validity?
Hi, yeah, this is Vilma Joseph. I just had a quick question regarding the fact that there was no missing data at all. I'm just amazed at that. That's like wonderful. So if the developer can explain that, or was this just an insignificant amount of missing data?
Yeah, thank you so much. I was reading the review comments yesterday, and so it was just very small numbers. So of the data elements, and so I had our data analyst pull some of our data for that, so just to get a general sense for the key elements. So for age, we had it was such small percentages that we just didn't delve deeper into doing an analysis of it. Age was he's very precise, 0.00044%. So very, very few missing values for age in the California Medicaid data set. And then larger missing data for diagnosis number one, although still very low at just 1%, one max of 2.3% for 2015 data. We looked at our 2014, 2015, and 2016 data, and it was 1.2% for the 2014, 1.4% for 2016, and then 2.3% for 2015. And then for the other piece that would be a key part of the measure was the NPI number, meaning how do you identify which provider was associated with the claim? And we again had very, very small numbers, 0.003% to even lower than that across the years. So very little missing data.
Thanks.
Yeah.
Other committee members with questions or comments about validity? All right, I think we can move to the vote on validity.
Voting is now open for measure 3668 on validity. The options are A for high, B for moderate, C for low, and D for insufficient. We will be waiting for 16 votes. Voting is now closed for measure 3668 on validity. There was 1 vote for high, 14 votes for moderate, 1 vote for low, and 0 votes for insufficient. Therefore, the measure passes on validity.
Well, that was fast. Very good. All right, Starlin, we'll move to a discussion of feasibility, which again, just to remind everybody, is the extent to which the specifications, including the measure logic, require data that are readily available and can be captured without undue burden and implemented for performance measurement. So Starlin.
So I'm proud to say the great Medicaid turn to electronic data collection in 1990 after over 90 was passed has probably helped us with this measure because we collect more electronic information and claims are rejected earlier and sent back to get. So I just wanted to say that sometimes we have less missing data in these days because we can check it faster, but not as fast as you think because we're not in real time yet. Anyway, so for feasibility, I'm confident that it's very feasible in Medicaid data. I'm concerned that if and I'm thinking that the commercial world would be able to feasibly apply this as well because they probably collect more data than what the Medicaid government entities develop. But I wanted to make sure I noted that all data elements needed to compute the measure are found in those defined fields. There's even some more. There are G codes that you can pull to see if it's telehealth or telemedicine, and you probably should need to add that. And that way you can see what the follow-up was like, and that would add some fidelity to the measure when you're looking at that post. There are some challenges in that linked claim data for emergency room. Again, I made the comment that sometimes emergency room hospitals make a deal with the Medicaid departments to get flat fee grants to cover some of what what normally ambulatory care, primary care would cover in an underserved area. So when I applied these, part of my master's thesis was on asthma in underserved areas of Chicago. And when we applied these principles, we had to go and look individually at each hospital emergency room and see what the percentage of they served as a primary care provider. So that would have to happen in those geographically. So that may be an issue, and you may be missing people because of that. But all data elements are available, and they indicated in their notes that they're ready to operationalize this. And now knowing that they also use Massachusetts and Vermont, that gives me a little more confidence about that. And the staff rated this validity or this feasibility as moderate. No, high. No, moderate. Sorry. Too many pieces of paper.
I think, thank you, Starlin. Lindsay, do you have comments?
I think the same concerns, just over identifying what claims would count for the follow-up visit, whether phone only, again, video or in person, and may have some state variability in terms of the coverage of that as well. So it could mean that different types of visits are included based on what states count as eligible claims based on their Medicaid criteria. But all of that is gatherable through claims. So all of it is feasible and no concerns with the rating of moderate. Maybe just a comment to developers in a world of specifically value-based care arrangements, and wouldn't want to hamper creativity in ways of delivering care that meets the intent of this, which is to provide that education and follow-up after an ED visit, and wouldn't want to overly anchor to a certain type of visit to do so as an unintended consequence. So maybe that's more on use than feasibility, depending on kind of what we include and what counts for those claims.
Thank you, Lindsay. Other committee members on feasibility? Naomi, just one quick question because it's come up a couple of times. Have you tested this in other states?
We looked at it in the California, Massachusetts, and Vermont states. Yeah.
Okay. Any other comments from the committee?
So what the benefit of doing it in Massachusetts, they have they are ahead along with California in ensuring their Medicaid delivery and electronic medical claim exchange is higher. Vermont probably is following on because they've tagged in with Massachusetts. What I wanted to say to the developers, the G codes, because we just for diabetes during COVID, we just updated all those CPT codes and ICD-10 codes and G codes so that there is a telephonic one, there's a telehealth one, and there's a telemedicine one, which means different things. If it's a telemedicine, you're doing some remote monitoring with it. So there are all those codes you can pull, and asthma has some remote monitoring capabilities as well. So those are things that you can pull in when you're doing your data claim pulls to see, especially now in 2022 instead of in 2015. So I just wanted to add that. Sorry.
Thank you, Star.
Yeah, thank you. Yeah.
Any other comments from the committee? Okay, let's go ahead with the vote on feasibility.
Voting is now open for measure 3668 on feasibility. The options are A for high, B for moderate, C for low, and D for insufficient. Again, we will be waiting for 16 votes. Voting is now closed. Measure 3668 on feasibility. We received 3 votes for high, 13 votes for moderate, 0 votes for low, and 0 votes for insufficient. The measure passes on feasibility. Thank you.
All right, thank you very much. So Starlin, we're going to talk about use and usability next. Use first, which is this metric being used by consumers, purchasers, providers, policymakers for both accountability and performance improvement activities?
So right now it's not in public, it's not in use across the board. They tested it in those 3 states with the Medicaid population. My point is, I think this is an excellent measure for the managed Medicaid. I often am frustrated with the quality of care managed Medicaid recipients are receiving. So to enforce this with the managed Medicaid groups to make sure they have follow-up would be excellent. It's kind of a political comment, but I review enough cases from the managed Medicaid groups to know that they're lost in follow-up. So they're ready to operationalize this, and it probably can flow very well in Medicaid data. I'm reserving commercial data, but if they pull enough of the right elements, they could create that pre-pull, the pull, and the post-pull, making sure all those ICD-9 codes and 10 codes are in there, because some people are still using 9s, and also the CPT codes that are purposefully related along with G codes to see if anybody's receiving any hybrid post follow-up healthcare.
All right, thank
Lindsay,
you.
did you have anything?
No, no concerns or extra comments on use.
So any other committee members on use? All right, Tristan, I think we can go ahead and vote on use.
Voting is now open for measure 3668 on use. The options are A for pass and B for no pass. Again, we will be waiting for 16 votes. Voting is now closed for measure 3668 on use. We received 15 votes for pass and 1 vote for no pass. The measure passes for use. Back to you, Dale.
All right, thank you. Starlin, we'll go to usability, which I always struggle a bit with the differences, but evaluates the extent to which audiences use or could use performance measure results for both accountability and performance improvement activities.
So the developer didn't share any potential harms or unintended circumstances. I failed to see if we're encouraging follow-up with the primary care. I guess the unintended consequence would be somebody, the person with the parents or the person with the disease would be annoyed by having multiple calls, but that's not a bad circumstance. That's keeping in touch with and getting engaged in your healthcare. So there's not much to go on. I'm interested in knowing what other people's comments are on the usability in their professional practices.
Lindsay?
Yeah, thanks, Dale. I mean, being a new measure, we don't have any data with regards to trends or how it has been used to improve performance. So the comments are speculative. I think on the positive side, or the positive consequences, would be encouraging health plans or other accountable entities to do better at rapidly getting PCPs or stakeholders notifications of ER utilization. As pointed out earlier, this is tough to come by in the current world, and often the notifications come after the window has passed for gap closure. So I think the incentives are right in terms of improving notifications to PCPs. Similarly, I think it could promote health plan outreach to at-risk patients to encourage visits through care management or other disease-oriented programs. Again, a positive. I do think the unintended consequence probably doesn't outweigh the former, but unintended consequence, especially with risk-bearing entities and value-based arrangements, health plan measures have a tendency to then be also used to evaluate PCP, especially performance as they're engaged in those relationships. So I think there's the potential concern that maybe absent great notification from a plan and absent a lot of outreach, the onus would fall on PCPs. I think especially in marginalized communities, as we pointed out, there was a disparity with lower follow-ups by Black patients. In current state, I think the risk could be, PCPs who care for populations who are at have other barriers to follow up in current state, inability to take time off work, et cetera, I think the risk is that those PCPs would be evaluated as being poorer performers on the measure. Again, it's not a PCP, not a provider level measure in current state, but I think we have seen this with health plan measures, especially in certain types of relationships where it becomes a way that PCPs are evaluated, which for things like this benefit those in affluent communities. So probably the fact that it's within the Medicaid population normalizes the sample a little bit, although we all know it's still not perfect. So I think those are the concerns. I'm not sure they outweigh the potential positives of use, but I do think they warrant discussion.
Yeah, thank you, Lindsay. Other committee members, and Leanne, I did get your note, and I will get to you here in a moment.
And Adele Kim Elliott has her hand raised.
Okay, thanks.
Yeah, I just wanted to say that with the Medicaid managed care rule that CMS has in place, the lack of requirements for notification of emergency department use will potentially not allow as much opportunity for usability of the measure because the plans, the accountable entities may not receive notice or be aware of that admission or that ED use until past the 14-day time frame. So it just creates this one little hurdle that makes it a little bit more challenging.
Yep.
Other committee members? So Naomi, I'm going to, and Leanne, I'll get to you before we vote on this. Now I'm going to ask you to respond to that last comment.
I think that I think it's an important point. How does this get operationalized into improved care? And as we discussed a little bit in the beginning part of the conversation, there's probably two pathways in which this can work. One of which is if somebody walks into the emergency department, then they would get contacted before that 14-day mark in order to get encouraged to get back into the primary care setting, either by the emergency department or by the health plan or by the or by a PCP, and having information flow is important. I think the other pathway through which this measure can drive improvement is actually just incentivizing health plans to help create those connections with primary care, particularly for our asthma patients. And so I think it's that other pathway that would also be an important pathway for us to just think about. That would be one part of the usability, and absolutely something that we'd have to keep on looking at as the measure gets more put into practice. I'll say one other thing, which is that we don't have published, but Vermont did some interesting quality improvement work, and they found that for their patients who did a lot of who were in a PCP office and then showed up in the emergency department later, it tended to be that they were patients who had uncontrolled asthma in the PCP office. So there's a little bit of a pathway for a PCP to sort of say, oh, we have to pay a little bit more attention to those kids. So that evidence base is still developing, but that's another sort of mechanism through which this might help people focus a little bit more. And I'll offer also Dr. Cabana if you have anything else to add to the discussion.
No, thanks, Dr. Bardak. Nothing else to add. Thanks.
All right, thank you. Anyone else on the committee? Okay, so before we vote, I'm going to ask Leanne to introduce Anna McAllister, who has joined us. Anna, it's great to see you.
Thank you, Dale. Yes, Anna, welcome to the meeting. We just need to pause a moment before voting just to have you introduce yourself, please. If you can come off mute, introduce yourself and your organization, and then any disclosures that you may have.
Hi there. I'm Anna McAllister. I'm here primarily as a patient advocate. I have no disclosures.
Wonderful. Thank you so much, Anna. Okay, now I'll hand it over to Dale. Are we ready for the vote?
I think we are ready for the vote.
Okay, we'll hand it over to Tristan.
Voting is now open for measure 3668 on usability. The options are A for high, B for moderate, C for low, and D for insufficient. We will be needing 17 votes. We are waiting for 2 more votes.
I'm having a hard time finding the link. Sorry.
Hey, Anna, we sent the link in an email around 8:30 a.m. Eastern time. If you need us to resend that, would be happy to.
Anna, this is Isaac. You can also send your vote directly to me via chat.
Okay.
All right, we're there.
All right, 17 votes. Voting is now closed for 3668 on usability. There was 1 vote for high, 15 votes for moderate, 1 vote for low, and 0 votes for insufficient. Therefore, the measure passes on usability.
All right, and so our last discussion is about overall rating of the measure for its overall suitability for endorsement. Is there any additional discussion at this point?
The only thing I'd like to bring up that if you look at any of the competing, NQF has 3599 pediatric asthma emergency department use, and this measure is harmonized with it.
Okay, yeah, we will get to that. All right, any other comments from any other committee members? Tristan, we'll turn it over to you.
Thank you, Dale. Voting is now open for measure 3668 on overall suitability for endorsement. The options are A for yes and B for no. Again, we will be waiting for 17 votes. One more vote. Voting is now closed for measure 3668 on overall suitability for endorsement. Therefore, the standing committee recommends to endorse the measure.
All right, thank you to our measure developers. Thank you very, very much for being here to help answer our questions today. Really appreciate it. And to the committee, I want to say you were amazingly efficient for our first measure of the morning. So good job, everybody.
Thank you very much. Take care.
Thank you so much. Yes, I echo, very efficient for our first one. So we have one more measure review before our lunch break. And so I'm going to give a moment for Victoria to pull up our slide, and I'll introduce our next measure, which is 2797, transcranial Doppler ultrasonography screening among children with sickle cell anemia. The measure developer, steward and developer is University of Michigan. This is a maintenance measure, and this is a measure that looks at the percentage of children ages 2 through 15 years old with sickle cell anemia who received at least one transcranial Doppler screening within a year. I will just actually pause a moment to see if our measure developer is on the line. So what I will do is I will hand this over to Adam, our co-chair, who will start leading the discussion. We'll proceed like the last measure, and I will reach out to the developer to let them know that we are beginning their measure evaluation. So Adam.
Thanks so much, Leanne. So thank you, everyone. We're going to begin to discuss this measure. Our lead discussant is Mitch Harris, and our supporting discussants are Kim Elliott and Brendel Glom. So Mitch, would you like to begin us off with a brief introduction of the measure and then an overview of evidence?
Sure. Thanks, Adam. So first things just to kind of mention, this was originally endorsed back in 2016. So this is the first time that this measure is up for re-endorsement, I believe. Again, it's a process measure. It's again, looks at the health plan level. And as previously mentioned, looks at the percentage of kids that are ages 2 through 15 that have sickle cell anemia and who received at least one screening within a year, intradoppler screening within a year. I don't think there's any sort of other sort of information. I can just move right into evidence if you want, Adam.
That'd be great. Thanks so much.
Okay, sure. So again, it's a maintenance measure. And so we're just looking here to sort of see if there was any new evidence that has been provided. In terms of a summary of the evidence that was in 2016, again, there was a systematic review of evidence for this measure. There was some quality and consistency of the evidence that was provided, and the evidence was graded. It's based off guidelines from NHLBI that support screening among kids with sickle cell anemia. There were, again, a couple of randomized trials and observational studies that were included in the evidence as well. Again, back in 2016, the committee did note that there were some differences between age specifications and the guidelines, but agreed that the measure aligned very closely with the NHLBI guidelines and sort of thought that that was okay. There has not been any changes to the evidence since the measure was last evaluated. So the staff rated the evidence for the measure as moderate. And in the pre-evaluation comments, again, there were just some notes again stating that, again, no changes to the evidence and some suggestions made that there's no need to repeat the discussion on evidence.
Great. Thank you so much, Mitch. Kim, anything you would add?
You covered everything I had reviewed. I was a little surprised that they hadn't done any updated evaluation or studies from 2016. It's quite a bit of time to have additional evidence build up, but the evidence, they said there were no changes, so I'm satisfied with that.
Great. Thank you so much, Kim. Brendel, anything you would add?
That was a concern of mine as well, with the update of evidence and predictability, I suppose.
Great, thank you. Any questions or comments from the committee? All right. Well, before we move to vote on the first area of evidence, we do have our measure developers that have joined us. Julie, I believe you're on the line. If you'd like to give us a hello and welcome and a brief overview of your measure.
Sure. Can you hear me all? Are you
Yes,
able to
ma'am.
hear me? Okay,
Yes.
terrific. Well, I'm Julie McCormick. I'm the project manager at the University of Michigan. Unfortunately, the measure developer, Dr. Sarah Reeves, is unable to join today. And I would like to note that I am going to have to leave at 11:30, and we sincerely apologize our limited availability today. But I would like to give a brief statement about the measure. As noted, the measure assesses the percentage of children ages 2 up to 16 years old with sickle cell anemia who received at least one transcranial Doppler screening within a year. This measure is supported by strong evidence. Without intervention, 11% of children with sickle cell anemia will have a stroke by the age of 18. Importantly, these strokes can be prevented. Transcranial Doppler or TCD screening is a non-invasive ultrasound method to identify children who are at high risk of stroke by measuring the blood vesicles in the vessels of the brain. Among those of higher risk, receipt of chronic blood transfusions dramatically reduces the risk of stroke. A 92% reduction was observed in a randomized control trial. Given the fact that TCD is the only method with which to identify children with sickle cell anemia at the highest risk of stroke, an expert panel at the National Heart, Lung, and Blood Institute, or NHLBI, strongly recommends that all children with sickle cell anemia should receive one TCD per year from ages 2 up to the age of 16. Therefore, in concordance with the NHLBI guidelines for annual TCD screening, our measure uses administrative claims to assess the proportion of children ages 2 up to 16 years with sickle cell anemia that receive a TCD screen within a year. As you know, there are many hemoglobin variations. Our measure focuses on HBSS cases, sickle cell anemia, which is consistent with NHLBI recommendations. Our denominator is the number of children with sickle cell anemia. We have tested the case definition for this denominator in both ICD-9 and ICD-10 by comparing various case definitions to the gold standard of newborn screening and choosing the most accurate definition. Therefore, this case definition is valid as it has both sensitivity and specificity of approximately 90% to identify children with sickle cell anemia as compared to newborn screening records. Our numerator is the number of children with sickle cell anemia that received a TCD screen. Receipt of TCD screen is identified through the presence of an administrative claim for the test. Again, we found that this method was valid as it is highly correlated with TCD screens found in the medical record. In addition to the strong evidence and validity of this measure, its application identifies significant opportunities for improvement in care among this vulnerable population. Since 2010, only about 40% of the children with sickle cell anemia received TCD screens when this measure was applied to Michigan and New York State Medicaid programs. This measure has shown no increase through 2019. The measure is currently in use in quality improvement initiatives, particularly in the state of Michigan. Working with the University of Michigan, the state Medicaid program has established a pilot program, a collaborative of Medicaid health plans within a specific region of the state designed specifically to improve the care of children with sickle cell disease. As part of this collaborative, Medicaid health plans within the region will receive financial incentives from the state if performance rates for this measure improve over the course of the next year. Finally, it is important to acknowledge that the majority of children with sickle cell anemia are within underrepresented and underserved racial and ethnic groups in the U.S. This measure directly speaks to health disparities experienced by this population as compared to other chronic conditions. In closing, we feel that this measure is highly important and has the potential to make a substantial positive impact on the quality of children's lives. Our measure focuses on the receipt of TCD screening, which is the only method in which to identify children with sickle cell anemia that are at highest risk for stroke. We found that this measure is highly valid and that the data elements to calculate this measure are readily available and administratively straightforward. We found that there is an important performance gap, and this measure is currently in use to incentivize Medicaid health plans in Michigan to improve the quality of care for children with sickle cell anemia. We strongly believe that endorsement of this measure will have a very positive impact on the health of these high-risk children. Thank you for your time and consideration.
Thank you so much, Julie. And Kim.
When you say that it's currently in use in one region in Michigan Medicaid program, what percentage of the Medicaid population then is included in that region? Do you have that data?
I don't have the exact number, but it is in Region 10, which is Southeast Michigan, where a majority of the children with sickle cell anemia receive their care.
Great, thank you so much. Any other questions or comments from the committee? Okay, and if no one has any objections to the evidence, because this is a maintenance measure, if there's no change, we can move directly to GAP unless somebody has an objection. If anybody has an objection and would like us to vote on evidence, you are welcome to let us know that, and you can either send a note to Leanne or Isaac and let them know, or let us know here in the chat room. Leanne or Isaac, have you received any objections?
I have not.
I haven't.
All right, well then I think we can go ahead and move on to the opportunity for improvement. Mitch.
Sure, thanks, Adam. So in terms of GAP, again, no new information provided in sort of the new paperwork, but again, looking back at sort of the information from 2016, there were rates provided from 6 states from both 2005 and 2010 that showed some slight improvement in these states. Again, from a low at some places to 5%, then maybe up to 51% improvement over the 5 years. Again, and then there's also some information that looked at GAP in the 2 Medicaid programs, one in Michigan and then one in New York, that also showed sort of even though there was some improvement, or actually improvement, but there still was GAP that remained with rates below 50%. In terms of information that was on any potential disparities, again, they did not have any data on particularly in terms of gender or income or socioeconomic status, but they did sort of look at information by age, and it was clear that sort of in some of the younger ages, they had a higher screening rate compared to children sort of that were in the older ranges. In terms of some of the pre-evaluation comments, again, there was just note that sort of the gap, an opportunity of improvement still exists, or at least sort of in the data previously existed. And the staff indicated the opportunity for improvement currently at moderate.
Great, thank you so much, Mitch. Kim, anything you would add?
No, I concur with everything that Mitch has said. There is opportunity. The level of performance is still relatively low. And although there weren't any socioeconomic, age, gender, any of those sort of disparity breakdowns, there clearly still evidence that supports that there is opportunity for improvement.
Thanks so much, Kim. And Brendel.
No, I think it's the demographic is set on this. I do think that this is a room for improvement for managed care across the board, and given the population, I think that a lot of them are represented within the Medicaid managed care population. So I certainly think that this is it's actually something I'm gonna take back to work and make sure that we're pursuing actively. I think it's a very valid and very useful measure, if a little long in the tooth.
Great, thank you so much, Brendel. Any other questions or comments from the committee members? All right, hearing none, I think we can move to the vote on GAP. Tristan?
Thank you, Adam. Voting is now open for measure 2797 on performance gap. The options are A for high, B for moderate, C for low, and D for insufficient. We will be requiring 17 votes. Waiting for one more. Perfect. Voting is now closed for measure 2797. There were 5 votes for high, 12 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on performance gap.
Great, thank you so much. Moving on to scientific acceptability, beginning with reliability. Mitch.
Thanks. So this, excuse me. So this measure was not reviewed by the scientific methods panel. So any comments that were provided, again, were provided by staff previously. The numerator and denominator statements appear straightforward. Again, there are no denominator exclusions. And so again, as the measure developer indicated, the numerator is the children aged 2 to 15 with sickle cell anemia who received one TCD screening within the measurement year. So again, it does look within that measurement year. And then the denominator is just the number of children in that age range with sickle cell anemia. In terms, and again, so no denominator exclusion. So again, in terms of specifications, very straightforward, and I don't think there are any issues brought up by the pre-evaluation comments. In terms of the reliability testing, again, this was done at the accountability entity level. They used the CMS max data from about 2005 to 2012 for 6 states, and again looked at some reliability statistics, and they were in the high 90% range. So again, the developer indicated there was a high degree of reliability. Committee stated that the specifications, they believe they can be consistently implemented and had no concerns. And again, the committee also indicated that it looks still reliable, and so there may not be a need to repeat the discussion and vote on reliability. The preliminary rating for reliability from the staff was moderate.
Great, thank you so much, Mitch. And Kim, anything you would like to add?
No, I just wanted to comment that since they were using the CMS max data and why it would only tie back to the accountable entity versus state Medicaid program or health plan level, because I think that would have been an easy, well, maybe not easy, but a way that you could have looked at the data as well, going past the 2016 time period. So I would encourage a developer to maybe broaden that a little bit so that there's a higher degree of a pay for performance or other sort of methodology that could be put in place if it's more broadly used.
Thanks so much, Kim. And Brendel.
I have just kind of maybe a follow-on question. Have we learned where in the system the failure to improve to the goal exists?
Any responses from our other discussants before we ask the measure developer at the end of this section? All right. Any other questions or comments? And then Brenda will bring your question over to the measure developer.
Thanks so much. Where's the breakdown, right?
All right, seeing no other questions or comments. Julie, any response to Brendel's question?
Yes, actually, we have an entire program working on that to answer that question right now. We're seeing a lot of difficulty in being able to reach the families of children with sickle cell anemia in Region 10. Right now, we see that there's a 60%, approximately 60% unable to reach rate for these families. So we're working with case managers and community health workers within the region on outreach. We're also, if children aren't being contacted, then we don't know if they're seeing their physicians, their primary care physicians, or a hematologist. So that's part of the work we're doing right now.
Great. Thank you so much, Julie. Brendel, any follow-up? Okay. Any other questions or comments from the committee? All right. So seeing as how this is a maintenance measure, we can choose, Leanne, keep me honest here. We can choose to accept the previous committee's decision that this measure is in fact reliable and move forward to validity. Unless someone has objections, which you are free to let us know now or message to Isaac or Leanne. All right. Isaac, Leanne, we good? See Leanne, thumbs up. Hold on, let me scroll down. I'll let Isaac interrupt me if he gets anything. Let's go ahead and move forward then onto validity. Mitch.
So again, just note that there had been no new validity testing updated for this measure. So again, all these information provided was from the original sort of endorsement back in 2016. There were 3 levels of validity testing conducted at that time. Again, there was the patient encounter level that looked at some chart reviews and looked at the the ability for the reviewers to agree, and that sort of had some high scores. And there was also sort of validity testing done at the accountability entity level, again using some of the Michigan MAX data and then some of the Michigan Medicaid claims data and comparing those, and those seem to have sort of a high level of reliability between the 2 sources. And then there was an expert panel, again, that looked at the face validity of this measure and rated it very highly and thought it would improve the care of patients with sickle cell anemia. So again, no new information provided at this time. And in terms of the pre-evaluation comments, again, no significant concerns were brought up with the validity testing or any other potential threats to validity, including the lack of risk adjustment or a lack of exclusions in this measure. The preliminary rating for this validity is moderate. And turn it back over to you, Adam.
Thanks so much, Mitch. Anything you would add, Kim?
Well, it's a rather straightforward measure with no risk adjustment or stratification. They didn't identify any missing data elements. It was claims driven. And I think that the measure, the way it's designed, can distinguish between poor and good quality care. So no concerns.
Thanks so much, Kim. And Brendel, anything you would add?
I do not. Thanks. Thank you to Adam.
Thanks so much. Committee, any questions or comments for our discussants on the measure?
So Adam, this is Mitch again, and just maybe sort of one comment to the developer, given their statement last time about sort of the trouble reaching out and being able to contact some of the children with or the families of children with sickle cell anemia. I'm wondering why they don't have any risk adjustment based on some socioeconomic, there are some new metrics out there like the Child Opportunity Index or some others that look at some area-based things that maybe would help if there are true differences in terms of, some of the perhaps issues with being able to contact families perhaps that live in specific areas or maybe that have resource limitations. So that may just be something to look at in the future.
Thanks so much, Mitch. Any other questions or comments from the committee? All right, so we did have updated validity information, so we do need to take a vote on this criteria. So I think no comments or questions at this point. We can move to validity testing vote. Tristan?
Thank you, Adam. Voting is now open for measure 2797 on validity. The options are A for high, B for moderate, C for low, and D for insufficient. We will be waiting for 17 votes. Voting is now closed for measure 2797 on validity. There was 1 vote for high, 16 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on validity.
Thank you so much, Tristan. And moving next to feasibility, Mitch.
So this measure seems pretty feasible to put in place. So all data elements are defined fields in electronic claims data. Again, didn't seem to be any sort of concerns from the pre-evaluation comments. Again, indicating that the data was available in electronic claims and seemed available and very accessible. And then the pre-rating was moderate by the staff.
Thanks so much. Kim, anything you would add?
Yep, I agree. The fields are accessible, the codes exist. It's all electronic claims or claims, so no concerns.
Thank you. And Brendel.
I think that this is easily performed.
Great, thanks so much. Great, thanks so much, Brendel. You were breaking up there a little bit, but I think it sounded like you got a little bit better there at the end. Any questions or comments from the committee for our discussants on the measure? Any questions folks have on feasibility for the measure developer? All right, I think we can move to a vote on feasibility. Tristan?
Thank you, Adam. Voting is now open for measure 2797 on feasibility. The options are A for high, B for moderate, C for low, and D for insufficient. Again, we will need 17 votes. Voting is now closed for measure 2797 on feasibility. There were 6 votes for high, 11 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on feasibility.
Great, thank you so much. And now moving to use and usability, beginning with use. Mitch?
Thanks. I think we're getting into the exciting part of this measure now. So a couple of issues that will come up in the next 2. I think in terms of use, again, previously it's been identified that it is not being used in public reporting. It is being used in accountability programs, in that they do have some planned use for accountability programs as well. Again, it's being used within the Michigan Medicaid program for a payment program to improve rates. And while they're not being currently publicly reported, the developer indicated that there are plans to be used in a quality improvement program, which I believe they mentioned earlier, to try to increase rates as well. The developer does provide the results to Michigan Medicaid Health on a quarterly basis. So again, there is certainly some use. It is in accountability, but not currently within sort of being publicly reported. Pre-evaluation comments focused on again the identification that again it's being used in accountability, not public reporting, but no sort of other significant issues. And the preliminary rating for this measure from the staff was a pass.
Great, thanks so much, Mitch. And Kim.
I would just like to put a question out there for the end of this discussion, Adam, on which other publicly reported programs the developer's working with. Otherwise, no concerns.
Thanks so much. I'll put that question on the list, Kim. And Brendel.
Here in Texas, it's not part of the public reporting. I am wondering about accountability, though, and to my comment a while ago about this, I'm going to follow up internally here and see where we are, both with accountability from state and feds, as well as how much we are holding our providers accountable.
Great, thanks so much, Brendel. Before we ask our measure developer, Kim's question, any questions or comments from the committee for our discussants? All right, hearing no, oh, Vilma?
Yeah, no, again, I was just curious about that 6-year window. So we are at that mark in terms of public reporting. Did they have any barriers to it at all? And they can talk about it.
Any response from our discussants before we move to the measure developer? All right. Any other questions or comments for the committee before we turn with our 2 questions for the measure developer? All right. Julie, are you still with us?
Yes, I will need to leave shortly, but I'm happy to do my best to answer your questions.
Awesome. So I think we've got 2 questions sitting here on the table. One of them is about the 6-year window that Velma was just talking about, and the other is Kim's question related to Kim. I've got it written down and it's scribbled and I can't even read it.
Which other accountability?
There you go. Which other accountability programs? Right. Thanks so much.
Well, this is probably a question, both questions are probably best answered by Dr. Reeves, but I will do my best. I understand that if this pilot program in the Southeast Michigan is successful in increasing rates, it is something that will be rolled out. There's been discussions about rolling out throughout the state of Michigan. So that's one issue. There's also discussions being made at the national level to possibly have this measure included in the core set of measures, CMS core set of measures. Those discussions have been ongoing for a few years now. It has been recommended 3 times for inclusion in the core set, although that has not happened. So that is something that is still an ongoing discussion at the national level.
Thanks so much. And Vilma, did you get your answer in there? All right, well, we will circle back around if we lost Vilma's question there. All right, any other questions or comments from the committee about use? All right, Tristan, I think we can move to the vote.
Thank you, Adam. Voting is now open for measure 2797 on use. The options are A for pass and B for no pass. We will be needing 17 votes again. Voting is now closed for measure 2797 on use. There were 17 votes for pass and 0 votes for no pass. Therefore, the measure passes on use.
Thanks so much, Tristan. And usability, Mitch.
All right, so this is in the area where I think there might be some work to do, but I'd love to hear from the developer too, if based on sort of what she said about the improvement project and if they maybe have some preliminary data that they could share. But again, while it is being used for different accountability programs, programs, it's not really being, information on improvement has not been shared over time. Really no information to be able to judge the usability at this point in time during the maintenance phase. So pre-evaluation comments again indicated that there certainly aren't any unintended consequences or harms because of the measure. But again, the lack of performance data calls into question against, I guess, the usability at this point. The preliminary rating from staff again on this measure was insufficient.
Thanks so much, Mitch. Kim, anything you would add?
Yeah, I agree with everything that Mitch just said. I am questioning why more information hasn't been put out in the last 6 years since the measure was first approved or recommended, endorsed by NQF. And if it's been in use in Michigan in the one region, Region 10, is there any data or information available as to whether the quality improvement work that's being done and the measurement resulting from that is resulting in improvement in care or outcomes for those individuals?
Great, thanks so much, Kim. And Brendel.
I agree with Kim completely. I think we're past time for some more updated data for substantiation of the measure. I support the measure, but it does seem like we've got to at some point we've got to be able to be sure that the measure is relevant and is being used as it should be.
Thanks so much, Brendel. Any questions or comments from the committee for our discussants?
So is she still here? I know she had to leave at 11:30.
I was just looking to check my participant list. That was my little secret ploy. I don't see her on here anymore. Julie, are you still with us?
I am. Yes, I'm still here.
Awesome. Do you want to speak as much time as you can give us right now about sort of the lack of updated performance improvement data?
So we do have data that we did not have available to share with you at the time that we made the submission, but we do have 6 quarters of data for the state of Michigan, specifically in Region 10, where the rates for this measure continue to be around 46%. Those last 6 quarters include January through March of 2022. We've initiated this collaborative with the state of Michigan. We are working diligently to change these rates and have these improvement programs in place. We do expect to see results over the next year. The state of Michigan will be starting the incentive program for July 2022 to July 2023. We have all of these supports in place to hopefully make changes in the care and in the performance rate for this measure.
Thanks so much, Julie. Any follow-up questions or comments from the committee?
I guess my only comment is that when I reviewed the evidence, and it's not a field that I follow closely, I don't take care of kids, but I was impressed by the potential risk for stroke that needs to be addressed. And honestly, there are a number of sickle cell metrics that we'll mention later in the related that are, I just don't know that anybody's holding anybody accountable for them. And yet they seem like they're really, really important. I can't tell you how many kids we have hitting emergency room all the time with sickle cell anemia. So I would hope that people would look at these carefully. If everybody's feels strongly that the evidence is good, that these should potentially be used as accountability measures.
Yeah, thanks so much, Dale. Any other comments or questions from the committee? All right, I think we can move to the vote, Tristan.
Voting is now open for measure 2797 on usability. The options are A for high, B for moderate, C for low, and D for insufficient. Again, we will need 17 votes. Waiting for one more vote. And voting is closed. Voting is now closed for measure 2797 on usability. We received 5 votes for high, 7 votes for moderate, 1 vote for low, and 3 votes for insufficient. Please give the team a moment to confirm the votes. The measure passes on usability. Back to you, Adam.
Thanks so much. So next up is overall suitability for endorsement before we discuss related and competing measures. So if there's any final comments or questions the committee has before we move to that final vote.
Yeah, this is Mitch. I'll just say that I think as we've sort of gone through, it's certainly a measure that seems like there's a lot of evidence for, that it seems fairly simple and straightforward to apply. But as Dale just mentioned, I think that the challenge then is sort of understanding why there's not more of a pickup in sort of the use of this. So it may be sort of just trying to, find levers to different organizations or groups that sort of can implement it. Because I do, again, think on the earlier points that we voted on, there's certainly a lot of evidence for this measure to be in place and more accountability in public reporting systems.
Thanks so much, Mitch. Any other comments from the committee? All right, I think we can move for overall suitability for endorsement.
Thank you, Adam. Voting is now open for measure 2797 on overall suitability for endorsement. The options are A for yes and B for no. Again, 17 votes. Voting is now closed for measure 2797 on overall suitability for endorsement. There were 17 votes for yes and 0 votes for no. Therefore, the Standing Committee recommends to endorse the measure.
Thanks so much, Tristan. And I think now a brief discussion on our related or competing measures, beginning Mitch.
Sure. So there were a couple of related measures indicated. Again, 3166, antibiotic prophylaxis among children with sickle cell anemia, and 3595, hydroxyurea use in children with sickle cell anemia. The developers indicate that they are harmonized with the current measure to the extent possible. Again, when looking at sort of the pre-evaluation comments from the committee, again, people agreed with that assessment and believe that there was pretty good harmonization.
Great. Thanks so much, Mitch. And I've been informed that I am way too excited about this to discuss related and competing measures, which we will discuss at the very end of our meeting, because between now and that part is actually your lunch break. So I don't want to be that guy that steals your lunch break for a conversation we're going to have later. So we'll put a pin in that when we come back to it. Thank you so much, Mitch, for providing that preview of our discussion that we will be having a little bit later. And I will pass it back to Leanne.
Adam, I love your enthusiasm to keep rolling. Yes, I will gladly give everyone the lunch break. Let's rest our eyes for a little bit, step away from the computer, get a good stretch in, get some food. We'll reconvene at 12:30, and we will start with, we have 2 composites, so definitely a good break, and then we'll come back, we'll do 0729 and then 3294, and we'll wrap up the day. So I appreciate everyone's participation. It's going super smooth and efficient. The voting's going great. So thank you all for being so engaged this morning, and I look forward to seeing you after lunch. Okay, it is 12:31 p.m. on the East Coast, so we'll go ahead and get started. Welcome back, everyone, to our Spring 2022 PCCI Measure Evaluation meeting. Glad to see you all back. We will move into our last 2 measures of the day, and so I'm going to pause and have Victoria share her screen so we can move to our 3rd measure, which is 0729. Thank you, Victoria. So our next measure is 0729, Optimal Diabetes Care. The measure steward and developer is Minnesota Community Measurement. This is a composite measure. The measure is the percentage of patients 18 to 75 years of age who have had a diagnosis of type 1 or type 2 diabetes and whose diabetes was optimally managed during the measurement period as defined by achieving all of the following: hemoglobin A1C less than 8, blood pressure less than 140/90, on a statin medication unless allowed contraindications or exceptions are present, non-tobacco user, and patient with ischemic vascular disease is on daily aspirin or antiplatelets unless allowed contraindications or exceptions are present. So with that, I will hand it over to our co-chair, Adam Thompson, to lead us in the discussions.
Thanks so much, Leanne. As we begin, I believe we have our measure developers with us, Colette and Julie. If you would like to give us a brief overview of the measure before we begin our discussion.
Great. Thank you. Good afternoon, everyone. I'm Colette Cole, a measure developer with Minnesota Community Measurement, and with me is Julie Saunier, our president of MNCM. We're pleased to be presenting measure number 0729, Optimal Diabetes Care for consideration of re-endorsement. This measure is a patient-level all or none composite measure that seeks to reduce modifiable risk factors associated with the long-term macrovascular and microvascular complications associated with diabetes. Patients with diabetes are more likely to reduce their overall risk, prevent or reduce complications, and maximize health outcomes by simultaneously achieving several intermediate physiological targets and medication adherence components. Leanne did a great job of going over the measure, the denominator, and its components. So I'm going to skip that part. These components are treated equally. There is no weighting of individual components. The scientific acceptability was reviewed and approved by both the Scientific Methods Panel and the PCCI Committee during the 2018 endorsement cycle. The measure has not changed since the last endorsement review, therefore scientific testing was not updated for the submission. In its preliminary analysis, NQF staff indicated a discussion during the 2018 maintenance review regarding the evidence supporting the use of all 5 components to improve outcomes. We'd like to address any potential concerns with the following information. The American Diabetes Association Standards of Care in 2022 have an A-level recommendation for the optimization of glucose and blood pressure control to reduce the risk or slow the progression of chronic kidney disease. In 2018, a study of over 270,000 patients with type 2 diabetes in Switzerland found that the excess risk of cardiovascular event outcomes decreased in a stepwise fashion for each risk factor variable that was within target range. Patients who were successful in achieving targets for all 5 risk factors had little or no excess risk of death, myocardial infarction, or stroke as compared to the general population. And lastly, Health Partners, a large integrated health system in Minnesota, has reduced the incidence of long-term complications of diabetes. Rates per 1,000 members between 2000 and 2017 fell from 17.8 to 9.1 for acute myocardial infarction, from 4.8 to 4.3 for amputations, and from 68 to 40.3 for retinopathy. For Health Partners and their approximately 42,000 members with diabetes, annually this equates to 361 fewer MIs, 20 fewer amputations, and 954 patients not experiencing retinopathy. This measure, originally developed by Health Partners, has been publicly reported in Minnesota for almost 20 years and is included in the Minnesota Department of Health's statewide quality reporting and measurement system, which requires patient-level data submission for all primary care and endocrinology clinics in Minnesota. On an annual basis, we are receiving data on over 315,000 patients with diabetes in Minnesota and surrounding communities. In 2020, the statewide average was 40.6% of all patients achieving all 5 targets, increased from our initial rate of 9.5% in 2006. Potential effects of the pandemic were noted with a rate decrease of 4.8% between 2019 and 2020. There is significant variability among practices, with the lowest scoring clinic at 5% and highest scoring clinic at 56.1%. Additional variability is highlighted when stratifying the measure by race, gender, ethnicity, insurance type, and neighborhood socioeconomic variables. Groups that had the biggest rate percent decreases were females, those aged 40 to 49, the uninsured, and higher socioeconomic status. The measure still demonstrates a gap and opportunity to improve. Please note that while the measure is an all or none composite, the individual components may be measured as well and are particularly helpful in quality improvement efforts to better understand where opportunities for improvement exist. Thank you for the opportunity to present this measure for your consideration.
Thank you so much for that overview. We really appreciate y'all coming today. Let's go ahead and turn to our committee discussants. Just as a reminder, because this is a composite measure, we will have a couple other criteria that we need to discuss. Let's begin with importance to measure, specifically evidence, and our lead discussant is James, and then we'll follow up with Ann and Robert.
Hello. Can you hear me? Yeah, I think.
Yeah, we can hear you.
So this measure is a long-standing measure. It's been used since 2006, and it's been used specifically in the state of Minnesota, it has been associated, at least we don't know if there's any causative effect of the use of the measure in improving these outcomes, but we've seen the substantial improvement of the measure itself over time, and correlated with individual components of them. Do you want me to go through the actual components again?
I don't think we necessarily need to do this at that point unless committee members have a specific question, because it is a maintenance measure. When we get to evidence, we can, as a committee, just accept the evidence vote that we had in our previous endorsement. So if folks have particular questions about it, if you want to put that in the chat room. If not, I think we can kind of go ahead and keep going with a higher level review.
Okay, the one specific thing that was listed in the measures is that they said in the material you sent me, it says hemoglobin A1C less than 8.0 milligrams per deciliter, and that's a mistake. It should be 8.0%. It's a percent. The hemoglobin A1C is measured as a percentage, not as milligrams per deciliter. Okay, so this composite has 2 intermediate outcome measures and 3 performance measures. Just to note again to the committee, 20 years ago, I was the chair of the operations group of the National Diabetes Quality Improvement Alliance, which developed the first nationally recognized performance measures for diabetes care. We existed until 2009 and disbanded then, but this measure actually used our materials back then in 2006. The thing about it is that a lot of the various measure sets that have been developed since then have changed, whereas this has been pretty constant since 2006. Because I have no conflict of interest because it was so long ago. Now, this is an all or none composite measure. The claim is that this should be considered the gold standard, reflecting best patient outcomes. However, of course, individual components might be measured as well, and there may exist similar individual measures for patients with diabetes related to its microvascular outcomes. The developers don't adequately explain why a composite like this should have specific benefit. They refer the staff and they refer to a Swedish study from 2018 that's cited, which reviewed almost 300,000 patients with diabetes over time, showing stepwise improvement in macrovascular complications in each of their targets as measures. However, the components are different from those in the measure under consideration. Their targets in that study were blood pressure of 140/80, not 140/90, which is in our measure. The hemoglobin A1C cutoff was 7.0% as opposed to 8.0%. Smoking, and they use smoking rather than tobacco use. Their LDL cholesterol was used, so they LDL cholesterol of greater than 97, whereas we're just our measure says whether or not they're taking a statin, period. No reference to specifically the degree of hyperlipidemia, and then in addition they use a presence of albuminuria as their fifth component, rather than our using the use of aspirin as an anticoagulant. Their outcomes are risk of death, myocardial infarction, stroke, and heart failure. So they really focused on the macrovascular complications instead of the microvascular complications. However, we all know from numerous studies like the DCCT, UKPDS, and EDIC that glycemic control is clearly associated with improvement of microvascular complications as well, and blood pressure has a big input. So, so basically, they're just we see comparisons of a composite measure achievement from 2006 to 2000, which improved substantially from 2006 to 2016. Then they stayed steady until 2020, and then they significantly declined in 2021, likely due to COVID-19. Now, the evidence they cite are the evidence of, they also show, I could mention it now, there's clear differences in performance by race, ethnicity, socioeconomic state, insurance, as well as other factors. Now, the evidence that they cite are the ratings in the 2022 ADA standards of medical care for diabetes. However, the ADA recommendations do not include a specific A1C target anymore. They had it originally. And they give a general goal of 7% and not 8%, with individual goals to be determined for each patient, either higher or lower than 7% based upon clinical factors like increased risk of hypoglycemia, limited life expectancy, etc. And they also encourage the use of shared decision-making regarding targets, which actually is summarized in the staff review document. The ADA statin recommendations are more nuanced than the ones in this measure, but they're generally reflected. The low-dose aspirin, is recommended by ADA for those with existing ASCVD or increased risk for ASCVD. This measure substitutes increased cardiovascular risk with just one item, which is LDL cholesterol greater than 190. And the blood pressure control recommendation in the ADA recommendations, they indicate 140/90 only for those patients with low risk or the presence of ASCVD. Patients with existing CVD or 10-year ASCVD risk greater than 15% should be treated with a more highly with a lower target of 130/80 if safely obtained. So this is a composite measure, but it clearly does not indicate optimal diabetes care. When it was, perhaps back in the day when it started out, it did, but it would make sense to call it more comprehensive diabetes care or adequate diabetes care. And it is true that if you're looking from year to year, usually these measures, whatever the cutoff is, they tend to go along with the they tend to track along with other cutoffs. Now, I just also want to mention that there are not many important measures of diabetes care that are not included here. They include eye exams at least every 2 years or more frequently, measurement of kidney function and micro or macroalbuminuria. There's no reference to any BMI or waist circumference, since weight loss is clearly a very important part of type 2 diabetes care. Then there's no mention of any behavioral interventions and no measures of diabetic dyslipidemia. Patients with high LDL, low HDL and high non-HDL cholesterol or high triglycerides are very important factors as well. So the best information we can glean from the measure is the long-term information it provides, since it was originated in 2006. And because they didn't change the measures over time, if they had, we wouldn't be able to compare performance from year to year. And for this reason, it should be considered a legacy measure. It makes sense to retain this measure for those who use it currently, but there's a big question as to whether or not it should be used for new programs starting out. Do you want me to discuss performance gap, opportunity for improvement, or should I stop there?
Yeah, no, we can stop at evidence because it's a different vote before we move forward. Thank you so much, James. Anne, anything you would add?
No, I don't think so. I agree that it's not really anymore considered optimal care, and there are components left out. Like, I don't think they talk about peripheral nerve evaluation or foot exam, things that we all know lead to complications of amputation. So, but it is trying to get at a more comprehensive low bar, probably. So I don't have anything to add to that.
Great. Thanks so much, Ann. And before we turn to the committee, Robert, anything you would add?
I'm aligned with everything that's said so far. But on the other hand, even though it's not optimal, there's still a significant opportunity to improve performance against this measure that addresses the two major areas of morbidity and mortality in this patient population, right? So the microvascular disease and the macrovascular disease.
Great, thanks so much. So turning to the committee now, just before we start making comments, when we get to the end of this, I see, Anna, that you got your hand up, so I'll come to you first. We can accept the evidence that was presented earlier as part of our vote, so just keep that in the back of your mind as we're having this discussion, or we can bring the evidence back up and take a full committee vote. Anna.
Hi there. I have never really loved this measure since it was first proposed to us, I think back on the endocrine standing committee when I was a member of that, which preceded this committee. And one of the issues that I have with it, although I have to say, I mean, I have type 1 diabetes, I take a statin, have taken 10 milligrams of Lipitor for more than 20 years, I guess at this point. I take low dose aspirin, have for more than 20 years. My A1C is in that range, blood pressure. I mean, so I understand the benefits and I understand the rationale for using each of these components very well. However, as the daughter of two people with type 2 diabetes, one of whom has had a history of severe reactions, like very severe reactions to statins, but because of quality measures that have been drummed into the heads of every PCP and cardiologist throughout the country, they keep putting her back on statins. Like a couple of years go by after she had severe reactions, they just put her back on statins. Nobody ever does any pharmacogenomic testing. I've had her tested. She does have a reaction to statins. Nobody takes that into consideration unless you throw that over their head. There's never any discussion with her. Anyway, if we're going to have these measures for a drug for which we know that 30% of the population has a tendency towards a severe adverse event, we have to have within the measure very specific counter measures that require and also measure the ability of the physician to be able to think through pharmacogenomic testing, or at least, if not PGX, which is readily available, asking about side effects and tracking side effects very closely, because it's really easy for a physician to think, oh, well, the patient has a bad outcome for a couple of months or 3 months, so we take the drug or we stop the drug and she goes on to something else. That's 3 months of life that are very substantial, can be problematic, and can interfere with compliance with other medical regimens that get very complicated with age and with life. And I mean, this measure has been on the books for how long at this point? In addition to all of the issues that were pointed out previously, there's still a significant failure to address this issue. And given how easy it is to address that issue, the fact that it still hasn't been taken into consideration within the context of this measure, just really I find to be problematic.
I just like to thank Anna for all the work she's done for us over the years. I mean, I remember her commenting on this 10 or 15 years ago. And the thing about the issue with statins is that since this measure started, there are a lot of other medications that are available for treatment of LDL cholesterol. Some of their data is not as clear cut as with statins in terms of reducing macrovascular events, but still, now we will usually put someone on another medication if they're intolerant to statins, and nothing is specifically discussed on that regarding this measure.
Thank you all so much. I did want to draw folks' attention to the chat room. Our measure developer, Colette, put in there that the measure has an exception for allergy and intolerance to statins and aspirin and antiplatelets. So I just wanted to put that there. And then, Kim, I saw your hand go down. Does that mean you were going to pull us to the chat room too?
Yeah, that's exactly what I was going to point out, that they do have that exception methodology for people with issues with statins, et cetera. Yep.
But there's no guidance to like have the physician give pharmacogenomic testing or specifically test for or inquire about adverse events. It just has that exception in, the denominator, which great, awesome, but like there's no compensatory requirement to like follow up on any of those issues or to do preventative testing. It just incentivizes people to use a drug for which there are alternatives.
Thanks so much, Anna. Any other questions or comments from the committee for our discussants related to evidence? Okay, hearing none. So we have two options, folks. One, we can accept the previous vote of the committee around evidence and move into importance to measure in the gap, or we can reopen the evidence vote and vote again. If anyone has objections to continuing forward to the next measure and accepting the previous vote, if you could let us know, either send Leanne or Isaac a note, or let us know in the chat room if you would like to vote on evidence. So let me make that clear, because I know that was a lot of things. If you're okay moving forward and not voting on evidence, let us know.
One thing I should measure one thing I should mention is that they are using they're using the ADA guidelines now and the evidence guidance for that, whereas prior to this they were using another set of diabetes performance measures that basically were derived from the ADA. So I don't know the differences between the older set, but that other organization, I think it's a Minnesota organization, that other organization is no longer in existence.
Thanks so much, James. And we did get some folks who would like to vote on evidence. So before we move to the vote, any last comments or questions from the committee on evidence? Okay, Tristan, can we go ahead and bring up the vote?
Thank you, Adam. Voting is now open for measure 0729 on evidence. The options are A for moderate, B for low, and C for insufficient. We are looking for 17 votes. One last call for votes.
Is anyone having difficulties casting their vote? If so, you can directly message myself or Isaac.
And voting is now closed for measure 0729 on evidence. There were 13 votes for moderate, 2 votes for low, and 1 vote for insufficient. Please provide us 1 moment. The measure passes on evidence. Back to you, Adam.
Thanks so much, Tristan. Moving forward, in importance to measure, looking at opportunity for improvement or gap. James.
Okay, so there are a number of performance gaps that are clearly demonstrated from the information they gave us. Statewide results show that 55% of patients diagnosed with diabetes have at least one component of the measure that was not optimally managed. And I discussed the Swedish study, but all 5 components, people people who actually had all 5 components of this measure had extremely low risk of major complications in their study. The main component for mortality is smoking in other studies, whereas we're talking about tobacco use, which I guess includes all sorts of other things like vaping and things of that sort. Regarding the impact, I think we're seeing very interesting data regarding the impact of COVID-19. A statewide measure decreases from 45% in 2019 to 40.6%. You know, more than 10% decline, and these rates declined significantly among females, a loss of 4.8 percentage points. The age 40 to 49 group, 5.4 percentage points. The uninsured, 12.9 percentage points, a tremendous decline. And people with high socioeconomic status had more than a lot of other people. They were actually 6 percentage point decline since the beginning of the pandemic. And the rate changes ranged from only a slight decrease of each individual component, that only ranged from a very slight decline of 0.1 percentage point for tobacco, but a 7% decline overall for blood pressure control, and hemoglobin A1C results very significantly increased in 2020. With regard to disparities, the developer also provided data related to COVID. Asians declined 6.3%, Blacks declined 5.4%, whites declined 4.6%, and indigenous natives 2.7%. Non-Hispanic declined 4.8%, whereas Hispanic declined less, 4.4%. So it was a wide range of performances among different ethnic groups, and I think this data is interesting and useful for follow-up. Okay, I think the quality. Does this include a discussion of the quality construct?
No, we'll move to that part next.
Okay, thank you.
Yeah, thanks so much, James. And before I turn to Anne, I just wanted to note in the chat room, Colette from the Measure Developer did note that tobacco is referring to tobacco products only and does not include vaping products. So they don't consider those tobacco use. So just to clarify there. Okay. Anne, anything you would add?
No, I think that's a nice summary, and it is impressive, the impact of presumably COVID.
So much. And Robert.
Just to emphasize, there's still a significant opportunity for improvement here.
Great, thanks so much. Any questions or comments from the committee for our discussants about opportunity for improvement? All right, hearing no questions or comments, Tristan, I think we can move to the vote.
Thank you, Adam. Voting is now open for measure 0729 on performance gap. The options are A for high, B for moderate, C for low, or D for insufficient. We are at 16 votes. Last call. Again, if you have any technical difficulties, please contact Leanne or Isaac. Last call. Voting is now closed for measure 0729 on performance gap. There were 6 votes for high, 10 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on performance gap.
Great. Thank you so much, Tristan. And again, because this is a composite measure, we do have a third criteria in this section, and that is looking at quality, construct, and rationale. James.
Okay, the idea, of course, is that a combination of measures can indicate a broader attention to overall care rather than individual measures considered separately. Each of the 5 components of the measure is important in and of itself, but the combination is indeed more effective at reducing complications. However, 2 of the measures are restricted to subpopulations. So aspirin use really applies only to those with existing risk factors or complications for those between 20 years of age and 40. Whereas over 40, it's for all of the people with existing complications. And then there is no weighting of the components of the construct. That's a significant issue. You know, there's no, because some of these components are more targeted towards specific negative outcomes. And the most recent hemoglobin A1C in the measurement period is less than 8.0. It applies to all the denominator patients. And the most recent blood pressure, less than 140/90, applies to all denominator patients. But statin use, if appropriate and no contraindications, exceptions, diabetics with age 18 to 20 have a free pass, and those with existing ischemic vascular disease on statin, unless LDL is less than 40, are exceptions in that category. And then diabetic age 21 to 39 and LDL greater than or equal to 190. That's for patients between 21 and 39. So if and then people have an LDL less than 190, which is the vast majority of them, they'll get a free pass. So so they're different. So it's kind of a little bit problematic in that each of these measures doesn't exactly measure the same population. They're measuring different populations. Okay, and the daily aspirin is also a complicated measure. If it's only for those patients with diabetes who actually have ischemic vascular disease, because we used to actually recommend daily aspirin for most people with diabetes, but now it's clear that a lot of the risks of daily aspirin, especially in young people, are actually outweigh the benefit. So it's been cut back to an older age population. So general grade on this I would give would be moderate.
Great, thanks so much, James. Anne, anything to add?
I think he summed up the issues quite well.
And Robert?
Nothing else to add, thanks.
Right. And to the committee, any questions or comments from folks for our discussants?
I would say moderate at this point is being generous. I mean, this measure has been on the books for a long time. We have had science come out in the intervening years. I think we need to take the things like the new understanding of aspirin, potential risks versus lack of benefits for aspirin into consideration. I think we need to take even a more highly developed understanding of the risks of statins under consideration. And I don't think it's adequate to just say, put a thing in the denominator to say that if people can't take those medications or if the risk factors aren't there or whatever the situation may be, then those people are not included in the numerator, because that stuff gets overlooked if the doctor's just trying to adhere to quality measures to meet their numbers. So we have to take responsibility for the unintended consequences of these measures. as well as the potential benefits. And this just no longer, I think it's been tenuous from the beginning. And I just don't think it makes sense. So.
Great, thanks so much, Anna. And I think Colette, I think you got your hand up.
Yes, hi, this is Colette from Minnesota Community Measurement. And if I may, I'd just like to address some of the comments. So yes, this measure has been in place for quite some time. However, we constantly are looking at the new evidence as it's arriving. And we have convened 3 different work groups to review that evidence. For example, when the measure started out, the A1C component was less than 7. With the results of ACCORD and DCCT, we rapidly convened a work group and looked at all of the recommendations and possibilities, and understanding that trying to capture some events like limited life expectancy, hypoglycemia, and other elements that would keep some patients from achieving a less than 7 target, our work group decided to go with less than 8. Subsequently, when the guidelines changed for cholesterol management, we had a more targeted physiological target of an LDL less than 100, but with new study that was no longer supported, and that was substituted with the use of statins and based on recommendations from the ACC/AHA. And likewise, when new blood pressure recommendations came out, I want to say about 2016, we again convened a development work group and reviewed that evidence and came to the determinations that we have today. In terms of the couple of components, for example, the aspirin, as that changed in evidence and guidelines, previously the target was diabetic patients age 40 and older were on daily aspirin. However, that with more evidence is not a safe thing. So we modified that component to just look at patients with known cardiovascular events and looking for aspirin on that. But in terms of the measure construct, patients who don't have ischemic vascular disease, they're not dinged or pinged for not taking aspirin because they shouldn't be, but they're, quote, given a free pass on that component. So I'd be happy to answer any other questions about kind of the evolution of this measure over time. Thank you.
Thanks so much, Colette. Any other questions or comments from the committee related to a quality construct? All right, hearing none, I think we can move to the vote. Tristan?
Thank you, Adam. Voting is now open for measure 0729 on composite quality construct and rationale. Options are A for high, B for moderate, C for low, and D for insufficient. We are at 16 votes. Last call for a vote. Last call. Voting is now closed for measure 0729 on composite quality construct and rationale. There were 0 votes for high, 15 votes for moderate, 1 vote for low, and 0 votes for insufficient. Therefore, the measure passes on composite quality construct and rationale.
Thanks so much. Moving on now to our next criteria, scientific acceptability. This will again have 3 sections to it: reliability, validity, and then empirical analysis. So let's begin with reliability. And first, James.
Okay, so there were no changes to the specifications of the measure since the last review. And I think that's appropriate because it's very important not to change things in midstream when you're undergoing, when you have a situation like COVID. And the reliability testing level was both on accountability entity level and also on the patient encounter level. So the reliability correlated with the number of eligible patients in the clinic and ranged from 0.51, 5.19 in the clinics with a maximum patients of 30, minimum patient of 30, and to the larger clinics, it was 0.994. So they indicate an overall high level of reliability to the measure score. So I'd rate this high.
Thanks so much, James. And Anne, anything to add? Oh, no. And Robert?
Nothing else to add, thanks.
Thanks so much. Any questions or comments from the committee for our discussants on reliability? All right, seeing none, I think we can move to the vote.
Voting is now open for measure 0729 on reliability. The options are A for high, B for moderate, C for low, and D for insufficient. You're at 16 votes. Last call for a vote. Last call. Voting is now closed for measure 0729 on reliability. There were 6 votes for high, 9 votes for moderate, 0 votes for low, and 1 vote for insufficient. Therefore, the measure passes on reliability.
Thanks so much. And moving now to validity, James.
Okay, so validity testing at the patient encounter level, the developer validated the elements by performing an audit and quality check of 53 medical groups, 30% of those submitting data, and a total of 89% of the medical groups passed the initial audit. 11% required a correction plan. And of those medical groups who resubmitted data, all passed the audit with greater than 90% accuracy. On the accountable entity level, I guess that means like health plans and so forth, the developer conducted validity testing for a composite score, and by testing the correlation of medical group performance with their care, with their performance on the overall measure, and they hypothesized that the quality of care should be similar. So linear regression analysis of the medical group's performance on the optimal diabetes care measure demonstrated a fairly strong correlation with its performance on optimal vascular care. With respect to the measure itself. So it was like the correlation coefficient of 0.629. And then they also conducted validity testing for the individual components of the composite, and using Pearson R correlation analysis. And for hemoglobin A1C, the correlation was 0.78. For blood pressure, the correlation was 0.71. For tobacco-free was 0.54. For statin use, 0.68. But aspirin or antiplatelet use was only a 0.26254. So that's pretty much what I have here for you.
Thanks so much, James. Anything you would add, Anne? No? And Robert?
Nothing else to add, thanks.
Thanks so much. Any questions or comments from the committee for our discussants? All right, seeing none. Tristan, I think we can move to the vote.
Voting is now open for measure 0729 on validity. The options are A for high, B for moderate, C for low, and D for insufficient. We are at 15 votes. Last call for voting. Last call. Voting is now closed for measure 0729 on validity. There were 2 votes for high, 12 votes for moderate, 1 vote for low, and 1 vote for insufficient. Therefore, the measure passes on validity.
Great. Thank you so much, Tristan. Moving to our last section here around empirical analysis. James?
Empirical analysis. Do the individual component measures add value to the composite and that the aggregating and weighting rules are consistent with a quality construct? This is an all or none composite measure. I sort of mentioned this before, each component reduces the modifiable risks associated with diabetes. The desired goal of the composite measures for patients to achieve intermediate physiological outcomes and medication use targets to best decrease their overall risk of developing microvascular and macrovascular complications related to diabetes. The developer used Pearson product moment correlation to measure the strength of linear regression of the relationships between the composite and its components. I think I mentioned this earlier, actually, but yeah, there was strong correlation with 4 out of the 5 components: blood pressure, hemoglobin A1C, and statin use and tobacco use, but aspirin use was very low. Then 618 clinics with 306,000 patients, correlation of performance. No, so that's enough. I don't need to.
Great. Yeah. Hold it. We're getting to there in just a second. Thank you, James. Ann, anything you would add?
No.
No. Robert?
Nothing else. Thanks.
Great. Thank you all. Any questions or comments from the committee related to empirical analysis? All right. I think we can move to the vote, Tristan.
Thank you, Adam. Voting is now open for measure 0729 on empirical analysis. The options are A for high, B for moderate, C for low, and D for insufficient. $15 votes. Last call for voting. Last call. Voting is now closed for measure 0729 on empirical analysis. There was 1 vote for high, 12 votes for moderate, 1 vote for low, and 1 vote for insufficient. Therefore, the measure passes on empirical analysis.
Thank you so much. Moving to our next criterion, feasibility. James.
Okay. The measure has been used in Minnesota without problems since 2006. The data is accessible and easily obtained. The number of patients and clinics are adequate, and the developer is implementing a new electronic data warehouse system, and there are no fees associated with the participation or data submission. So I would say feasibility is high.
Thanks so much, James. Anything you would add, Ann? Nothing. And Robert?
I'd just add that the data is captured in the routine delivery of care, so it doesn't provide any additional burden to clinicians.
Great, thank you so much. Any other questions or comments from the committee for our discussants on feasibility? Right, hearing none. Tristan, we can move to the vote.
Voting is now open for measure 0729 on feasibility. The options are A for high, B for moderate, C for low, and D for insufficient. $16 votes. Last call for voting. Voting is now closed for measure 0729 on feasibility. There were 12 votes for high, 3 votes for moderate, 0 votes for low, and 1 vote for insufficient. Therefore, the measure passes on feasibility.
Thank you. Moving now to use and usability, beginning with use. James?
Use, it's actively used in appropriate locations in the state.
Awesome. Ann, anything you would add?
I agree.
And Robert?
Agree.
Any questions or comments from the committee for our discussants on use? All right, we can move to the vote.
Voting is now open for measure 0729 on use. The options are A for pass, B for no pass. $16 votes. Last call for voting. Voting is now closed for measure 0729 on use. There were 15 votes for pass and 1 vote for no pass. Therefore, the measure passes on use.
Thank you. And moving now to usability. James?
Okay. The developer, basically, the measure is included in 2 state regulatory programs, the Minnesota Statewide Quality and Reporting System, and it's also included in the Minnesota Healthcare Home Certification Recertification Program. So the provide statewide performance gap data for achieving all the 5 components of the composite measure, as well as the individual performance rates in each of the 5 components. So statewide rates increased from 9.5% in 2006 to 53.5% in 2015, which is a very substantial improvement. But then it had remained level until about 2019, and then it went down. So it's now 45.4%, or at least in 2020 it was. And then there was a decrease in most of the various outcomes, which I measured before of these various rates of the components. Benefits versus harm, is that included in this as well? So the benefits of the performance measure in facilitating high quality, efficient care outweigh the incidence of unintended negative consequences to individuals or populations. The unexpected findings, there were 2 unexpected findings. Adults aged 65 and older with Medicare have better outcome rates than younger adults with diabetes due to generational differences related to providers' orders. And then statewide A1C averages are trending upward, which is a trend that the ADA has confirmed. And also, of course, I gave information earlier about the impact of COVID-19, and this is important because COVID-19 and diabetes are linked in the sense that people with diabetes tend to have worse outcomes when they are infected with COVID-19. And in certain situations, COVID-19 can actually aggravate or problems with diabetes control.
Great, thanks so much, James. Anything you would add, Ann? No. Robert?
Nothing else to add, thanks.
Any other questions or comments from the committee for our discussants on usability? All right, I did just want to myself bring back in the comment, I think what Anna was talking about earlier, the potential harm associated with prescribing the statins to folks who have the reaction to it. I know it wasn't mentioned in the measure developer, but I just want to kind of bring that forward again in this section. All right, if we have no other questions or comments, I think we can go ahead and move to the vote.
Thank you, Adam. Voting is now open for measure 0729 on usability. The options are A for high, B for moderate, C for low, and D for insufficient. $15 votes. Last call for voting. Last call. Voting is now closed for measure 0729 on usability. There were 5 votes for high, 10 votes for moderate, 0 votes for low, and 1 vote for insufficient. Therefore, the measure passes on usability.
Great, thank you so much. Last section, overall suitability for endorsement. Any comments or questions from the committee members around the measure in its totality?
I'd like to say something. Just, overall, there are a lot of problems with this measure, but I think it should be continued, certainly in this population. The question is whether or not we can recommend the NQF can recommend it for use or endorse it for use elsewhere. And I would be unlikely to want that to happen, but I'm not sure we can make that kind of exception. So it's just the point that I'd like to make.
What do you mean by that in terms of NQF versus?
Well, I think that a new composite measure should have different. It would be better if it had different criteria within the composite. The 5 categories are not necessarily the best 5 categories to look at, and also the cutoffs are different from what we would necessarily like as optimal diabetes care. Nevertheless, it's been very useful in Minnesota, and I think especially during the period of COVID now that we're following, we really need to see follow-up data for the next few years to see where things are going.
Thanks so much, James.
And I'll just reiterate what I've said before. I mean, I don't know how many times I need to say it, but like the consequences on individuals' lives can be significant. And I have never felt like, whether it's the measure developer or NQF or committee, has taken those consequences as seriously as they should be. And it's super easy from the perspective of public health to overlook the consequences on individuals when they're outliers. It's really easy. And I don't know, I'm not like a measure developer expert. I don't have any kind of secret sauce in terms of like dealing with outliers. But when you put together composite measures that have no compensatory requirement for any kind of risk assessment or mitigation baked into the measure, a busy physician dealing with an elderly patient, like the level of lack of respect and dismissiveness that gets translated in that environment is significant. Even if the patient is educated, articulate, they get ignored. So anyway, we need to evolve our approach to how we define and measure quality. And I feel like we're not doing that. And it's very frustrating.
Thank you so much for sharing, Anna. Any other comments from the committee?
I just want to let Anna know that we definitely appreciate your feedback on the measures under review, and we do review the measures as specified. We can definitely take these recommendations and your feedback and note those in our reports for the developer. We just want to clarify that we can't endorse for specific use. So just to clarify that, but we can, the standing committee endorses measures as specified, and those recommendations can be noted, and we will make sure we note those in our summary and our draft report. So thank you for that.
Thanks so much, Leanne. Any other questions or comments? All right, I think we can move to the vote for overall suitability.
Thank you, Adam. Voting is now open for measure 0729 on overall suitability for endorsement. Options are A for yes and B for no. $15 votes. Last call for voting. Last call. Voting is now closed for measure 0729 on overall suitability for endorsement. There were 13 votes for yes and 2 votes for no. Therefore, the standing committee recommends to endorse the measure. Back to you, Adam.
Thanks so much. And we will be holding on related and competing measures, no matter how excited I get about them at the end of our process. So I think now I'm going to be passing it back to Leanne.
Thank you, Adam. So we are about to embark on our last measure under review for this spring cycle. So I'm going to pause while Victoria pulls up our slide deck and we see our measure here. So this measure is a surgery composite measure, measure 3294, STS lobectomy for lung cancer composite score. The measure steward and developer is the Society of Thoracic Surgeons. This is a maintenance measure. I will provide the brief description of the measure. The STS lobectomy composite score comprises 2 domains: operative mortality, death during the same hospitalization as surgery or within 30 days of the procedure, presence of at least one of these major complications: pneumonia, acute respiratory distress syndrome, bronchopleural fistula, pulmonary embolus, initial ventilator support greater than 48 hours, reintubation, respiratory failure, tracheostomy, myocardial infarction, or unexpected return to the operating room. The composite score is created by a weighted combination of the above two domains, resulting in a single composite score. In addition to receiving a numeric score, participants are assigned to rating categories designated by star ratings: 1 star, 2 star, and 3 stars. So I am going to hand the baton over now to our co-chair, Dale Bratzler, to help lead us through the discussions of Measure 3294.
All right, finally, I'm having mouse problems. I couldn't get the mute button pushed. So thank you for that introduction. Not sure who we have on for Measure Developer. It says that maybe Dr. Michael Furstenberg will give the brief introduction of the measure to start with. I don't know if Michael's here or one of the other members of STS.
Yeah, so Michael is our lead discussant, but I do believe we have members of our STS developer.
Yes, Leanne. Hi, this is Bani Aja with the Society of Thoracic Surgeons. Here with me today, I have Dr. Jeff Jacobs, Dr. Dave Shaheen, and Dr. Moritz Weiler von Balmus. We're very happy to be here. And right after Dale, Dr. Jacobs will proceed with the introduction of our measure.
Right. So hi, this is Jeff Jacobs. It's nice to be talking to you all today, and thank you for your service to National Quality Forum. I think that the previous introduction to the measure said the majority of what I had planned to say anyway, but what I can tell you is that this is measure maintenance on multi-domain composite. It's one of many multi-domain composite quality measures in the STS portfolio of measures, and this one deals specifically with lobectomy for lung cancer, which is the most common surgical procedure done in patients with lung cancer. This composite measure has been reviewed and published in the peer-reviewed literature. It was published in the Annals of Thoracic Surgery in 2016, and the measure was developed by utilizing an analysis of the STS General Thoracic Surgical Database. As was stated before, this is a composite score that is developed based on 2 outcomes: risk-adjusted mortality and any or none risk-adjusted presence or absence of major complications. The model was developed utilizing data from the General Thoracic Surgery Database over a 4-year analytic window, and 95% Bayesian credible intervals were utilized to determine and categorize performance with a star rating system utilizing 3 stars. The analysis was performed with a study population of 20,657 patients undergoing lobectomy for lung cancer at 231 hospitals across the United States. In that analytic cohort, the operative mortality was 1.5%, and the rate of major complications was 9.6%. The median postoperative length of stay was 4 days. Risk-adjusted mortality and major complication rates varied threefold, from the highest performing 3-star providers to the lowest performing 1-star providers. And after placing all of this information into the STAR system, the multi-domain composite categorized hospitals as 88% in the 2-star domain, 5% in the 1-star domain, and 7% in the 3-star domain. After publication of this analysis in the Annals of Thoracic Surgery, this measure was incorporated into the STS General Thoracic Surgery Database, initially where it was utilized for feedback to participants in our feedback reports that are distributed every 6 months to the participants, and subsequently it was also included in the portfolio of measures that the Society of Thoracic Surgeons publicly reports. So I think that's a quick introduction of this measure, and there's 3 STS surgeons as well as Banu from the STS office on the phone, and we're all happy to answer any questions that may arise during the discussion. Thank you.
All right, thank you, Dr. Jacobs. I appreciate that. So I'm sorry, the lead discussant today is Dr. Michael Furstenberg. So Michael, are you on the call?
Yes.
Okay, great. I'll turn it over to you to discuss the evidence.
Yeah, no, I mean, it's great to see everybody again. And Jeff, it's good to see you again. It seems like we're kind of tag teaming these things every couple of months.
Yeah, it's good to see you, Michael.
To, I guess, kind of be brief out of respect for everybody's time, this is a pretty well validated model within the STS that runs parallel to many of the cardiac metrics that are publicly reported and tracked in a similar fashion. The data is kind of collected from all the participant sites. While it is somewhat voluntary, it is sort of encouraged that everybody that participates in this procedure submits all their data. It's been validated. It's been used for years, and it's hard for me to really improve on the articulate presentation that Dr. Jacobs put together. But this is probably as robust as they get for a quality metric for the surgical treatment of early stage lung cancer. I think it incorporates very robust statistical modeling, highly effective data collection that's been validated, again, many times over the years, and is publicly reported, published in the peer literature, and it is something that is pretty well respected by everybody at this point. Probably it in a nutshell.
All right. Thank you. Our supporting discussants, Miklos Kurtai.
Thank you. I concur what Dr. Fistenberg said. It's a robust, well-validated, to be proven to be very useful risk prediction tool. So I have no concerns.
Hey, Dr. D'Agostino.
I echo the comments, and I have no concerns either.
All right, thank you. Anyone else on the committee have any questions or comments about the evidence for the metric? All right, hearing none, I believe we can move to voting on the evidence.
Thank you, Dale. Voting is now open for measure 3294 on evidence. The options are A for pass and B for no pass. We are at 15 votes. Last call for voting. Last call. Voting is now closed for measure 3294 on evidence. There were 15 votes for pass, 0 votes for no pass. Therefore, the measure passes on evidence.
All right, thank you. So, Michael, I know in the introduction, Dr. Jacobs talked a little bit about performance gap, but if you would highlight performance gap.
Well, I mean, I think it is something that has been validated over the years. I think, one of the challenges, the variability in the number of cases that are presented from programs. You range from kind of small, intermediate, and large. But I think that, again, that has been pretty well developed within the, the STAR rating program that is consistent. And so, again, it kind of captures all the information, and I don't think that there's any substantial performance gap in any of this.
Wait, I think maybe
Do I?
I think there is a performance gap.
I'm sorry?
There should be a performance.
Yeah. So there are, some concerns about, just the, sometimes the underrepresentation, according to this, of the demographics, in terms of, who gets presented, particularly those with different types of insurance, whether it's Medicaid or private insurance. But I don't think that this is anything that warrants, as we, the question is whether there's a national performance measure, whether there's any opportunity for improvement. I think we just need to continue to capture the data. And I think, the disparity related to the number of cases does sometimes potentially impact smaller programs that may do less volume, and that statistically 1 or 2 cases may throw off their numbers. But I think that is somewhat adjusted in the risk adjustment models that are presented. Does that address, I think, what you're looking for?
Well, I think what we're thinking about when we talk about performance gap is there still an opportunity to improve performance on the measure? And I see Dr. D'Agostino shaking his head yes, and I believe that's what I heard from Dr. Jacobs.
Yeah, that is correct. I agree. There is an opportunity to improve here. The developer, as it is indicated in the evaluation document, identified a significant disparity between whites and non-whites in terms of the performance and outcomes. So indeed, there is a performance gap, which provides an opportunity for improvement, caring and providing care for minorities.
Even more fundamental than that, Bill, I would say that until we have all patients with lobectomy having no complications and no deaths, there is a performance gap, and we are substantially nowhere close to that.
Yeah, I that's exactly what I was going to say. I think the data shows that there's still an important number of hospitals that perform at the 1-star level in this measure, either in one domain or the other domain or in the overall composite, and that represents a performance gap with opportunities for improvement.
Yes, I agree with that entirely. The other thing to point out is that the performance gap that you highlight here in terms of the ethnic backgrounds, I think it's also important to understand that the thoracic surgeons are downstream in the referral process. So they will get their patients referred to them from pulmonologists and primary care and internists. So some of the gaps that you see in terms of the ethnic backgrounds are reflective of the care and the referral practices of the referring physicians. But clearly there's an opportunity for improvement and an opportunity for outreach to our referrings.
I think the other comment that was brought up, and maybe others can address this better, is the fact that this really just captures the majority of the data, I think, performed by thoracic surgeons. And I think that there may be a lot of these types of operations or similar or lesser operations that get performed throughout the country by general surgeons, and how much of that data is captured and how much of that is accurately reflected in the overall data set.
I'm going to check and see if there are other members of the committee that have questions or comments. I'm going through some of the pre-evaluation comments. Other members of the committee who have comments or? Okay, well, I think we can move forward with voting on performance gap.
Voting is now open for measure 3294 on performance gap. The options are A for high, B for moderate, C for low, and D for insufficient. "15 votes. Last call for voting." Voting is now closed for measure 3294 on performance gap. There were 5 votes for high, 10 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on performance gap.
All right, we'll move forward, Michael. Discussion of the quality construct and vote on the composite itself.
Yeah. So the composite construct looks at not just operative mortality during either the index hospitalization or within 30 days, but a variety of complications that are pretty well described and defined, and those then get used to risk adjust everything into the different levels of star ratings. With regards to this, the question then is, including some of the current data as to the role of minimally invasive lung surgery and whether that can continue to improve overall outcomes in morbidity and mortality, and whether additional measures can and should be included to try to optimize this.
Dr. Curtime?
I agree with Michael. And in addition to that, I'd like to add that, as was discussed and briefly described by Dr. Jacobs, this is a robust quality construct. And there is proven evidence over the years that there is basically how the rationale, how the risk prediction model was designed and validated. There's also at the time basically, and publications and all of the above indicated that this is a clinically useful prediction model which can withstand the test of time.
Okay, Dr. D'Agostino?
Yes, I agree. I think this is a very robust model and includes the not only mortality, which obviously is the most significant thing, but also encompasses the very important complications that are meaningful and have been shown to impact outcomes. So this I have no concerns on this at all.
Any questions from the committee on the construct of the composite?
I like this is Vilma. I like the fact that they changed it over time. Before it was 1-to-1 mortality versus complications, and now it's 4-to-1 mortality versus complications. So I thought that was pretty insightful, and that they're willing to change over time to realize that, mortality is important, but you definitely have to also incorporate complications.
Any other comments from the committee? Okay, I believe, Tristan, we can go ahead and vote on the composite.
Voting is now open for measure 3294 on composite quality construct and rationale. The options are A for high, B for moderate, C for low, and D for insufficient. We are at 15 votes. Last call for voting. Voting is now closed for measure 3294 on composite quality construct and rationale. There were 6 votes for high, 9 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on quality construct and rationale.
All right, thank you. So we'll go on with scientific acceptability. Michael, if you could talk about reliability.
Sure, I lost the I'm sorry, the reliability is the next one? Sorry.
Yes.
I thought I was going on something else, but the I think the overall reliability reflects that this is data that's collected more or less in real time, submitted voluntarily to the STS, where it's been validated, risk adjusted, and adapted in real time with comparison of the different groups, or excuse me, the different contributing programs ranging from 30 cases per year all the way up. I think it's been consistent over time. It's been validated, and the correlation coefficients show that that it is, again, predictable, reliable, and reproducible.
Dr. Kita.
I agree with Michael. Measure specifications have not changed since the last review, and these specifications are very clear and precise, so I don't have any concerns.
I agree. The specifications are very well defined, and they absolutely can be consistently implemented. No concerns.
So I don't know which member of our committee, somebody just highlighted the reliability scores that were in the submission, that they were in the 50 to 60% range. And of course, I'm not exactly sure how that was measured. A little bit higher for larger groups. Higher volume had higher reliability. I don't know if anyone from the measure developer wants to comment on that. Or...
Yeah, I think that the measured reliability is certainly still within what's acceptable for performance of a measure. So no measure has perfect reliability, but certainly the numbers that we have and the numbers that we documented in our submission are within what one would view as acceptable and suitable for both feedback to participants and also for public reporting.
Anyone else on the committee have any questions or comments? It's a quiet committee this afternoon. So we'll move on to voting on reliability.
Thank you, Dale. Voting is now open for measure 3294 on reliability. The options are A for high, B for moderate, C for low, and D for insufficient. We are at 13 votes. Last call for voting. Last call. Voting is now closed for measure 3294 on reliability. There were 2 votes for high, 11 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on reliability.
All right, very good. So validity, discussion of, does the measure actually reflect the quality of care given? So Michael, validity?
I think in brief, again, emphasizing, we're looking at probably some of the most important quality metrics out there, and that is, morbidity and pretty well established, mortality and pretty well established major morbidities that are associated with this procedure. And it's been consistent over time. And I think it is a very important and robust series of metrics that programs can and should be evaluated against, and that the public can use to try to help determine where they want to get their care from. So I think it's extremely valid.
I agree with Michael, and in addition to that, from an analytical sort of angle, in all 6 domains that are listed under validity, the composite construct performed well, and any questions, concerns have been adequately addressed.
Yep, and I agree as well with Dr. Kurtai.
Okay. And looking through the pre-submission comments, I don't see any great concerns here. I think it was pointed out in the comments that the composite score did correlate with actual patient outcomes such as mortality, which seems to support validity of the metric. Anyone else, any other committee members?
Yeah, this is Vilma. I just had two quick questions. One, I just wanted them to go over how they handled the missing values. You know, they said they were imputed. So, in terms of, just getting the average, do they think that's sufficient, for those certain variables? And the other one is the fact that there was no social risk stratification that they documented. I understand they said that they don't collect, data on race and ethnicity, but they do collect insurance, because we saw that in terms of the number of cases. But I was wondering, what are they planning on doing in the future with regards to risk stratification?
I could address the SES issue if I could.
Sure, go ahead.
We are in the process right now in the STS database of acquiring geocoded area deprivation indices for all our patients. We've started first with our adult cardiac surgery database, but we are hoping to expand this throughout the database. We believe that area-based indicator, and many of you on this Zoom conference are familiar with that. It comes out of the University of Wisconsin. It's based on 17 SES variables. We think that's the most comprehensive single SES indicator there is. And I hope that when we come back to you next cycle for re-endorsement, that we will actually have that ADI indicator incorporated.
Thanks, David. What about, I want to make sure that we covered the question on just missing data. So this is voluntarily collected, submitted by the facility or the hospital systems that participate in the database or the surgeon.
I can make a few comments on that. First of all, all STS databases take missing data very seriously and realize that the missing data can have impacts on our risk models. So the first piece is that in order for any hospital or database participant to have their data included in STS aggregate data, receive feedback reports, and have their data included in our public reporting initiative, that hospital is required to meet certain very stringent levels of data completeness for the key important fields, including operative mortality, which really means 30-day status and discharge status. And if a hospital does not comply with those minimum standards of data completion, they're not even included in the aggregate data, and they don't receive feedback reports, and they cannot publicly report. The number of hospitals that don't meet those requirements has decreased substantially year after year after year. And now there's very few hospitals that do not have adequate completion of data and very low rates of missingness on the key important fields. Beyond that, to more specifically address this question, during model development, STS uses mechanisms of multiple imputation to deal with missing data. I'm not a statistician, I'm a heart surgeon, but I do know that the statistician who works with us, who's a PhD statistician at Duke University named Sean O'Brien, is really a world leader on this type of methodology to deal with missing data. And he tells us that the multiple imputation methodologies used in all STS risk models are really state of the art and the best way to handle missing data during model development. And I think that's about as deep as I can go with this discussion.
Okay, thank you. Any other committee members have questions or comments? All right, Tristan, I think we can move to voting on validity.
Thank you, Dale. Voting is now open for measure 3294 on validity. The options are A for high, B for moderate, C for low, and D for insufficient. We are at 14 votes. Last call for voting. Voting is now closed for measure 3294 on validity. There were 3 votes for high, 11 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on validity.
All right, Michael, next section is on just the empiric analysis of the composite.
Sure. So with regards to that, the analysis is based upon, as we mentioned, the operative mortality and major complication rate for the 186 hospitals that are contributing at least 30 lobectomies per program over the 3-year period, which then is used to generate the risk-adjusted model that then goes into the STAR rating system, both for mortality as well as major complications. As has been discussed, this is all a component of the reporting system within the STS. There is appropriate weighting that is given to all of this, and I think that there's a very high level validity and for this composite measure in the empirical analysis to support how we're doing this.
I can echo that. I don't have any concerns about the empirical analysis for validity.
I agree with that. I don't either.
All right, and I'm just looking through the pre-meeting comments, and it looks like there were no concerns reported. Anyone else on the committee have questions or concerns about the metric? Saying shaking heads no, so make sure there's no hands raised. Okay, we'll go ahead and with the vote. Tristan.
Thank you, Dale. Voting is now open for measure 3294 on empirical analysis. The options are A for high, B for moderate, C for low, and D for insufficient. We are at 13 votes. Last call for voting. Voting is now closed for measure 3294 on empirical analysis. There were 2 votes for high, 12 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on empirical analysis.
All right, thank you. Feasibility, Dr. Michael, you want to talk about feasibility? This is voluntary data collection, as I understand.
I mean, it is voluntary data collection, but I think it's, for the most part, something that we all embrace as being a key core component of our professional obligation to, the patients, the public at hand by reporting this. And I think people recognize that by, as Dr. Jacobs alluded to, if you're not participating in it, then that does sort of reflect a little bit on your program, and it is sort of a badge of honor, so to speak, to be actively engaged. So it it is something that I think everybody takes pride in participating in and trying to get the best numbers as possible as part of a quality improvement program that we all need, if nothing else, for our maintenance of certification as well. So I think it's very strongly supported.
Dr. Kidai?
I agree with Michael. It is very strongly supported within the thoracic surgery community, and the thoracic surgeons take pride in participating in the process, and really helps them to improve and understand the ways they can improve the outcomes of their patients. So I don't have any concerns about the feasibility.
And neither do I. And I think it's also important to point out that the data elements are routinely generated and available electronically and are well defined. So it's I have no concerns about feasibility.
So I just want to make sure, because it's been a while since I looked at the STS data sets and their variety of metrics that STS has. So much of the data is available in electronic data fields, but I assume that still is transferred somehow into a separate reporting tool of some type.
So, so the data is entered on site at a given hospital by data managers. The data managers have extensive training, including an annual data managers training course that's available both in person and online, as well as monthly webinars that teach them about data quality and data entry requirements. Those data are entered at the local hospital in the overwhelming majority of cases. Then they're uploaded to our data warehouse, which is a company called IQVIA. And the data from the data warehouse then undergoes data analysis at the STS analytics centers. And once it's analyzed, it's then used to populate feedback reports, which are sent back to the hospital participants, benchmarking their individual results against national aggregate data. And it's also fed into the public reporting platform, excuse me, for those hospitals that choose to publicly report. I'm not sure if that answered the question. I think it did.
Yeah, I think it did. Dr. Curry, you had a comment, question?
So a challenge that we have in our health system is identifying those who have died out of hospital. So how does this group, how do these groups identify somebody that's died within 30 days of the procedure but out of hospital? Sounds like it might have to be a manual process to have some accuracy.
That's a great question, and it's been a big area of focus for the Society of Thoracic Surgeons across all of our databases. You're absolutely right that it's easier for a hospital to enter into a database whether or not a patient was alive at the time of hospital discharge than it is to verify life status at 30 days if the patient was discharged home prior to 30 days. You're absolutely right about that. And it's something that STS has focused on over the years to develop methods to capture this data and to assure that it's complete and accurate. We know it's accurate from our audit process. We have one of the largest audit processes of any registry on the planet, where 10% of the sites are randomly audited on an annual basis. And the audit includes validation or verification of a number of important fields that are in our risk models, including obviously discharge status and 30-day status. So we know the data is accurate in those fields. In order to assure it's complete, as I described before, hospitals are required to have 98% completion of the 30-day status field in order to have their data included in the aggregate STS data and to receive risk-adjusted outcomes for their hospital. And that 98% was increased over a number of years from 90% to 95% to 98%. So we've encouraged hospitals to be complete because it's required for participation, and we encourage accuracy through our audit process. Beyond that, we require documentation of how 30-day life status was verified if the patient has been discharged home before the 30 days end. So one way is that there's proof of life in the electronic health record. Another way is that the patient comes back to see the surgeon for a follow-up visit. That probably covers over 90% of our verification of life status at 30 days. But for the remaining 10%, additional efforts are needed, which could include telephoning the referring doctor to check on the status of the patient, or even calling the patient themselves. For most cases, those steps are not necessary because the patient comes back to see the surgeon for follow-up, where there's proof of life in the electronic health record.
I would just add to what Dr. Jacobs said, that we are looking for other methods as well to verify 30-day mortality. In the past, it was possible to use a Social Security death master file. That's no longer feasible, but we have established a relationship which should allow us to use the National Death Index. So again, by the time we come back to you for our next measure re-endorsement, we hopefully will be able to use National Death Index data. And in terms of manual versus some other form of data entry, we believe right now that manual abstraction is the most accurate, but we also realize the data collection burden that imposes on programs. So we actually, STS has established a contractual relationship with a major university center to explore automated methods for extracting some of the data elements. Even if we could reduce data collection burden 30 or 40%, it would be major, as long as we don't sacrifice accuracy. So again, that is an ongoing project that actually looks very promising.
Thanks, Dr. Sheehan. Any other comments or questions from the committee? Seeing no more hands raised. All right, Tristan, can we go ahead and vote on feasibility?
Yes. Voting is now open for measure 3294 on feasibility. The options are A for high, B for moderate, C for low, and D for insufficient. We are at 14 votes. Last call for voting. Voting is now closed for measure 3294 on feasibility. There were 4 votes for high, 10 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on feasibility.
All right, thank you. All right, Michael, if you want to talk a little bit about use, how's the measure being used at this point? Did I lose you, Michael?
It's muted.
Sorry about that. This is this is used and incorporated into just about every major thoracic program that's out there. Obviously, there's some smaller programs that don't meet the volume criteria that may not necessarily get a reporting score, but that doesn't mean that they're not submitting. In fact, probably every major program is using this extensively, both internally for their own quality improvement initiatives, as a component of all the STS data that they get, as well as those that are doing well, really emphasize the public reporting nature of it in terms of their program growth and development. So this is used extensively.
Dr. Ketai?
I agree with Michael. This is used extensively in an accountable and transparent way.
And Dr. D'Agostino.
Dr. D'Agostino, I believe you're on mute. We were unable to hear you.
Thank you. I was saying to myself that the GTSD, the thoracic database, provides 2 reports a year, feedback reports to all of the participating sites, and that gives an immense amount of information for quality improvement. And the results are publicly reported, so the public can easily look that up.
So I actually, that was one of my questions. I noticed in the review, it was listed as publicly reported. I assume that's predominantly voluntary at this point. In other words, a center could participate, but not necessarily, or do you require it to be released publicly at this point?
The STS public reporting initiatives are all voluntary. I think the only entity that can require public reporting would be the government. And as a professional medical society, we can facilitate public reporting and make it voluntary. That being said, we have very high rates of public reporting, with close to 90% in our congenital heart surgery database, close to 85% in our adult heart surgery database, and an increasing number every year of participants in the general thoracic surgery database. So we continue to make efforts to encourage as many participants as possible to voluntarily publicly report. But in the absence of us being the government, and instead with us being a professional medical society, that's what we can do. We can encourage our participants to publicly report.
Yeah, that was my sense. Thank you. Others have questions on use, comments? I'm trying to scroll through and make sure I don't miss raised hands here. Anyone else on the committee have any questions or comments about use? All right. Seeing none, Tristan?
Voting is now open for measure 3294 on use. The options are A for pass and B for no pass. Thirteen votes. Last call for voting. Voting is now closed for measure 3294 on use. There were 14 votes for pass and 0 votes for no pass. Therefore, the measure passes on use.
All right, Michael, can you talk a little bit about usability? How do the centers who get these reports, how are they using it?
As has been mentioned, there's periodic reporting of the data that's been validated and provides essentially, the risk-adjusted outcomes of all these things that most programs incorporate into their ongoing continuous quality improvement projects that work hand in hand, both between the hospital and the surgeon and the surgical teams and other disciplines. And, and as you can see by the data that's been reported, that there is this ongoing reduction in mortality and major morbidity that is essentially attributed to the fact that this data is being tracked and reported and does drive quality initiatives, particularly with the emphasis on kind of the star rating system, so that people feel that if they do embrace these things, they can get rewarded for being better beyond just the fact that they're helping their patients. So they see the data and they can track their own institutional improvements. I think it's used extensively everywhere.
Dr. Kurtai?
Agree. And the data and the feedback and the reports are used extensively in local as well as national level type of quality improvement initiative programs related to the outcomes of thoracic surgery, including lobectomies. So I don't have any specific concerns about usability.
Dr. Diaz.
I agree with Dr. Kurtai. I have nothing. I have no additional concerns.
Okay, and I'm looking through the pre-meeting comments, and essentially there were no concerns, no unintended consequences that were identified, no harms, and some good news that overall surgical or operative mortality has decreased from 1.2 to 1% since 2015. So good news there. Anyone on the committee have other questions or concerns? James.
Yes, could the experts describe how the star system, rating system is used and at what levels it's used? Because I don't know exactly how performance translates into stars.
Yeah, I can try to tackle that one. So first of all, the statistical translation of performance into stars is based on Bayesian modeling. And this model is used utilizing 95% credible intervals where outliers are true outliers with 95% Bayesian certainty. So that's how one actually identifies if a program is a 1-star, 2-star, or 3-star. Once a program is identified as a 1-star, 2-star, or 3-star, this can be tracked year after year after year to examine trends in performance. 3-star programs can be studied to find out what are they doing that's good, and other programs can learn from these 3-star programs. And 1-star programs can do internal analyses to identify opportunities for improvement, to learn strategies by what they need to do to become a 2-star program because they've been identified as negatively performing outliers. Beyond that, STS is now in the process of creating a site visit program where expert surgeons from the Society of Thoracic Surgeons will be available for consultation to visit any program, to evaluate the program and offer opportunities and suggestions for quality improvement. And this is a service that STS will provide to facilitate opportunities for 1-star programs to reach out to STS, ask for a site visit, and ask for advice on what that program can do to improve. But I guess the one-sentence answer to your question is that outliers are identified through statistical methodology, which is sound, and therefore that allows identification of programs that are performing worse than expected, as expected, or better than expected.
And just to expand a little bit on that, the underlying assumption to start with at the beginning of the analysis is that all programs are statistically indistinguishable. Then we look to see whether the entire credible interval of a particular program is wholly above or wholly below the STS average, wholly above the score is wholly above 3-star, wholly below 1-star. And it is possible the way this is done that we would have no 1-star programs if everybody was performing at a very high level. There is no, unlike methodologies that use percentiles, for example, there's no obligatory 1 or 3 stars. And actually our goal would be to have every program in the country that's participating in this program be functioning at such a high level that we could not distinguish them, and they would all be operating at an extraordinary level. We're not anywhere near that, but that would be our goal.
Any other questions or comments from the committee on usability? All right. Leanne, I don't think I've missed anybody. So Tristan, I think we can go ahead with the vote.
Thank you, Dale. Voting is now open for measure 3294 on usability. The options are A for high, B for moderate, C for low, and D for insufficient. We are at 14 votes. Last call for voting. Voting is now closed for measure 3294 on usability. There were 6 votes for high, 8 votes for moderate, 0 votes for low, and 0 votes for insufficient. Therefore, the measure passes on usability.
All right, thank you guys very much. So that brings us to the last category, which is overall suitability for endorsement. I'll just open it up and see, does anybody have any comments? Michael, do you have any comments, or anyone else have any comments or questions for the measure developers?
This is a cornerstone for the thoracic oncology reporting system. I think it really sets the lead for just about everything else that's done in medicine and surgery, as kind of concurrent with, as Dr. Jacobs and colleagues alluded to, congenital heart disease reporting, as well as adult cardiac disease. Kind of the 3 pillars of kind of pushing accountability within medicine, to the forefront, that I think a lot of other disciplines are also working towards. And it's stuff like this is without a doubt the most important reporting that we need to do. This needs to be endorsed unconditionally, in my opinion.
I agree with Michael, and it has a downstream ramification effect also. Cardiothoracic anesthesiologists working with thoracic surgeons, they work together and really sort of piggyback on the reports from the Society of Thoracic Surgeons, General Thoracic Surgery Database reports on morbidity and mortality, how to improve outcomes. So it's really a measure that drives quality, safety, and outcomes in the thoracic surgery patient population.
Any other comments or questions about overall suitability for endorsement? All right, hearing none, Tristan, let's take the final vote.
Final vote. Voting is now open for measure 3294 on overall suitability for endorsement. The options are A for yes, B for no. We are at 15 votes. Last call for voting. Voting is now closed for measure 3294 on overall suitability for endorsement. There were 15 votes for yes and 0 votes for no. Therefore, the Standing Committee recommends to endorse the measure.
All right, thank you guys very much. Thank you to all of our STS colleagues. Really appreciate you being here today and helping us understand this important performance measure, and enjoyed working with you today.
Thank you very much.
Yeah, thank you all very much, and thanks for the service that you provide. You guys are doing important work.
Thank you all.
Thank you, everybody.
So I think I turn it over to Leanne at this point.
Thank you, Dale. And thank you to the entire Standing Committee and the developers for the great discussions we had today. And I know it can be a long day, but we did a great job reviewing these measures, and we definitely appreciate all the time that went into these measures. I have on the agenda a 10-minute break between the end of our measure review period and then the beginning of our related and competing discussion slides. I will open it up to the Standing Committee. If you would like to take that 10 minutes to stretch and grab something to drink or use the restroom, we can do that, or we can move forward with the related and competing and the next steps. So I will leave it up to the Standing Committee. So is there any objections to continuing on with the meeting?
Not for me, but I would prefer to get some time back at the end of the day.
Okay, so I will, while Victoria's pulling up the slides, if I hear anything different, we'll just kind of power through and go through the related and competing. So I will give her that moment to pull those up. Okay, All right, so I'm just going to provide a brief overview of what is considered competing and what is considered related. So next slide, Victoria, please. A competing measure is the same concept and the same target population. In these instances, the standing committee would need to have a best-in-class discussion. We do not have any competing measures for this cycle. We also have related measures where there are different target populations or a different concept. If they both are different, we don't have competition between those measures and no harmonization is needed. If there are some similarities, developers are asked to harmonize their measures with the other related measures appropriately. Measure harmonization refers to the standardization of specifications for related measures with the same measure focus or the same target population, or if the definitions applicable to many measures so that is a uniform and they're uniform and comparable, unless those differences are justified. The dimensions of harmonization can include numerator, denominator, exclusions, calculations, and data source and collection instructions. The extent of harmonization depends on the relationship of the measure, the evidence for the specific measure focus, and differences in those data sources. So next slide, please. Before we begin the related review, I just want to note that this will not change the endorsement vote in any way, but the recommendations will be noted in the final report for future evaluation by the standing committee. So we can discuss harmonization and make those recommendations. Okay, next slide, please. So our first related measure that we'll review is 3668 and the related measure 3559, which is pediatric asthma emergency department use. The next slide, please. We did put the details of 3599 up on the slide. The measure developer notes in their submission that 3668, follow-up after emergency department visits for asthma, is harmonized with measure 3559 on age range and with the ICD codes used to identify the eligible population and exclusions. Next slide, please. So for this related measure, we would like the standing committee to consider these three questions. Are these measure specifications harmonized to the extent possible? Are there differences that could impact interpretability and add data collection burden? And are the differences justified? So I will pause a moment to open it up to Dale and the standing committee, see if there's any recommendations.
So I'd open it up. I'll just start with just a couple of comments. I think although the target population is the same, the measure concepts are different. One is measuring percent, use of population-based use of the emergency department. The other measure is looking at whether the patient followed up after an emergency department visit for primary care or specialty care visit. So I think overlap with the target population is quite appropriate, and I don't see them competing otherwise. My thoughts.
Perfect, thank you, Dale. And anyone else from the standing committee? Any feedback? Thoughts?
I completely agree. This is Anna. I completely agree with Dale. I mean, they're looking at the same population, same kind of care setting, but they're different measures.
Wonderful, thank you for that feedback. Okay.
Leanne, this is Brendel. I agree with them, and it's a little bit skewed of point and purpose, but I don't see them directly competing with one another, and both probably useful.
Wonderful, thank you, Brendel. Just take a moment. Hard for me to see the hand raises, so I'm scrolling through the chat.
Yeah, me too. Keep scrolling.
And I don't see anything in, Starlin agrees with Dale as well in the chat. So I just want to pull that up for the record.
Any other comments from anyone about these two metrics?
And then Kim agrees that they're different measures.
For measures, yeah.
Perfect, thank you so much. All right, we'll go to our next slide. So this measure is 0061, Comprehensive Diabetes Care Blood Pressure Control, 140/90, and this is has been identified as a related measure to 0729, our Optimal Diabetes Care Measure. Next slide, please. So in their submission, the developer notes that the two measure numerators are harmonized and that there are differences in the denominator definitions due in part to the data source. The developer for 0061 uses claims data to identify diabetic patients, whereas Minnesota Community Measurement uses EMR-based data. The developer for 0061 uses methodology that looks for diabetic diagnosis codes, but additionally will include patients on oral medications and insulin who do not have the diagnosis. Lastly, Minnesota Community Measurement notes that the diabetic women who are currently pregnant during the measurement year are excluded from measure 0729. So I will pause here again for those three questions that we have related to the related measures and see if anyone has any feedback or recommendations for harmonization.
If I remember correctly, we have a lot of competing diabetes measures, or at least measures related to the specific elements of this composite measure. So are we just taking this one measure at a time in terms of the measures that could be potentially competitive with the composite measure, or how is that working?
So that's a great question, Anna. So what we're doing is we're looking at do these two measures that for example 0729, 0061, they were identified as related. So they had the same target population, but different and or same concept or measure focus. And so we're looking at, are these measures harmonized to the extent possible to reduce the burden of data collection and use by accountable entities? And if there are recommendations by the standing committee, we can note those in our final report. I hope that answered your question. Or is there additional questions on that? These were not identified as competing, which would be the same concept and the same target population.
Okay.
These two measures are both are they being curated by the NQF itself?
So the other measure was submitted by the National Committee for Quality Assurance, and I believe is already NQF endorsed.
Okay, NCQA. Okay, so how did they get the data from all the complete data from claims? From claims, I don't understand how they get like the blood pressure and so forth. Looking at the claims data.
So for measure 0061, we're not reviewing that measure. I don't have that measure specification in front of me, but that would be definitely something that would be in the developer's specifications for 0061. And Dale is correct, that measure is currently NQF endorsed.
Okay, well, yeah, well, Minnesota is unique in the sense that it has a very high use of electronic records. So that's why you could see that this is being used in Minnesota. The other thing is that both measures include patients on oral medications and insulin who do not have the diagnosis of diabetes. And also patients who are currently pregnant during the measure year. Well, the problem with this is the problem with the other measure, not the one that we're reviewing here, is that lots of the pre-diabetes is being treated with a lot of these medical agents. So you're really dealing with a population that includes a substantial amount of people who don't have diabetes and have pre-diabetes. As I said, this is a problem with the other two measures, not for the measure we're analyzing. So it's hard to harmonize, so to speak.
And I still want, I mean, this one specifically calls out blood pressure, which is a part of the composite measure, but we also have measures around A1C, and other elements that are part of the composite. So like, I don't understand why this one is being singled out as a competing measure and those other measures are not.
So this measure, Anna, was it was identified as a related measure by the developer, and we did look at the NQF endorsement SAS 40061 for the related measure. There was no other measures with the components that were identified as related. But I'm going to ask Matt Pickering to also weigh in on this. So Matt, if you can add more detail around the components and the composite related.
Yeah, so just with the composites, what you're looking at here is not only just the composite, if there's any sort of harmonization that needs to happen there at the composite level, but also the individual components. So if you're looking at the components, if there's different patient populations or different focus areas, is the measure harmonized to the extent possible? And there could be justification as to why they're not harmonized to the extent possible. Sorry for the dog barking. It could be because it's a different care setting. It could be a different level of analysis. There could be some justification as why there's some differences, whether you're looking at, the blood pressure levels or whatever. They could be using some different data sources for that, but the use may be different. So you're looking at the composite score itself, but also looking at the individual components of those composites to see if there's harmonization with those measures since they're related. And again, there may be a reason why they're not harmonized to the extent possible because of, like I mentioned, just different care settings, or even different levels of analysis.
Okay. I mean, I don't know if any of the others who's been on the committees for as long as I have recollection of some of the other specific components of this measure that have their own measures, but it feels kind of duplicative to me. And I haven't looked at those measures in a while, but I don't think the care settings are all that distinct. But anyway, we don't need to belabor the point.
Well, so Anna, I think I understand what you're saying. When you look at the components of the Minnesota measure, there are other performance measures that focus on some of those components. For instance, percentage of patients with a hemoglobin A1C less than 8 or less than 9. There are a variety of measures out there. Tobacco use. There are a number of tobacco use performance metrics out there. So the various pieces of this composite measure actually have other performance measures that I believe some are likely NQF endorsed. I was trying to look for some of them. Can't find them on the NQF website, but I'm sure they're there.
So as I said, the big difference is that these two other measures define diabetes differently. And in the past, there wasn't much of a difference because we didn't use a lot of these agents like metformin and some of the other agents for treatment of pre-diabetes. But now we do. And that means that a large percentage of the patients for these two measures, 61 and 59, a large percentage of them won't have diabetes as is defined for our measure, the measure 729. So it needs harmonization if you want to. Otherwise, it should not be considered harmonized.
James Madigan from NQF. So is that, you had mentioned this a little bit earlier. You had said that the concern really is about the other two, not that this measure, 0729, but the other two measures may not be as expanded as they need to be to capture diabetes patients? Is that the concern?
So a lot of this measure, the denominator includes a lot of people who do not have diabetes. Okay, And the title of these two are under comprehensive diabetes care. So we used to feel comfortable using and there weren't very many, when this measure was created, it's a very old measure, 61 and 57. But when this measure was created, and I know this was part of our data set, and when it was created back then, very few people, we used the use of diabetes medications as a way to define
Right.
the patient had diabetes. And here, quite clearly, now that a large number of people are using certain medications to treat pre-diabetes, it means that there are different denominators, different populations, and it's not really purely diabetes care. It's diabetes and pre-diabetes care. And almost all, in addition, almost all people with pre-diabetes already have hemoglobin A1Cs under 8.
I guess though, what I want to point out is that NQF, you chose this measure because the measure developer listed it as potentially a competing measure. Is that why we're talking about this one?
So we, correct, Dale. So in the measure submission, the developer identified 0061 as a related, not competing, just as a related measure. So again, either the same population and or same concept. If it were same target population and concept, then we would look at it as and consider it as competing. So this one was identified as a related measure. And so and then they discussed how they harmonized the measures to the extent possible.
Okay, I guess the point I'm making, I think the one that Anna's making is, so I am on the NQF website now, and NCQA has another measure, 0575, which is hemoglobin A1C control less than 8%. I think that's part of the component that we reviewed today. Another one on LDL-C control. So in other words, and I'm probably not doing a really comprehensive search, but there are other measures around other pieces of the component for this particular metric that I think, are very similar, just like 0061 has some components of the measure that are similar to one piece of the composite measure we reviewed.
Yeah, and that's the point I was making. It's like, why are we just looking at why was this pressure the only one that's a potentially competing measure when we've got measures for all of the other components? And does NQF do a search of the measures? Does the staff do a search of the measures to identify competing measures? Do we just rely upon the developer to offer those up? Trying to understand the logic.
It's both, Anna. Yeah, so there's definitely what the developer has provided, and staff do try to present that to the standing committees, as well as other measures that potentially could be related or competing. And then it's looking at those measures to determine, as this measure has come through as being passed, is there any further harmonization that needs to be considered? And this would be recommendations both for the current measure that has come through, but also thinking about recommendations for the measures that currently are endorsed. Those other measures that are currently endorsed will come back through NQF maintenance endorsement. So capturing those recommendations within this forum would be helpful for the developer of those measures also to consider how they could potentially harmonize further, especially with this measure that's coming through. But there may be a need or a reason why there's not fully similar numerators and denominators. Like I mentioned, if there's a different focus or a different care setting, or maybe even different intended use for the measure, there could be justification of why the numerator denominator or the measure focus is a little bit different.
And so completely agree with that. I understand that. I'm just back to Anna's point. There are other measures that NQF has already endorsed that include other components of this composite. So the developer gave you 0061. I would argue 0575. I'm sorry. Yeah, I think it's 0575 is similar to one component of the measure. I know NQF has a bunch of tobacco use or tobacco cessation performance metrics. And I haven't even looked up aspirin and ischemic vascular disease, but there may be other measures. And again, I think there, as you point out, there are very good reasons the denominator may be different. I get that. That's completely acceptable. Or the way the data is collected, how it's collected may be different. I get that. But there are other measures that overlap, I think, with components of this composite beyond just this one on blood pressure control.
Yeah, it doesn't make logical sense to me that we're just looking at this one measure as a competing measure where, Dale just listed off the numbers, but I know from sitting on these committees for more than a decade that we've got other measures that address the components. So, I mean, again, I don't need to belabor the point, but it just doesn't make a lot of logical sense. And then, more broadly speaking, I think it's great and important for NQF to ask us and to take a look themselves at competing measures and making sure that we're keeping them consistent, that they're not, we're not coming up with confusing recommendations or quality measures. But I would also encourage NQF to think more broadly. And again, I'm not going to keep belaboring the point about statins, but if we're going to have measures where when we endorse these measures, we know that there will be consequences for, in the case of statins, 30% of the population, by most recent estimates, have some sort of adverse event. We need to come up with complementary measures that also require mitigation for the harms that are caused by the measures that we endorse.
Yeah, and thank you very much, Anna. And we definitely take that in consideration. It is, NQF obviously doesn't develop the measures. So if there is a recommendation from the standing committee that there should be a balancing measure or another measure that looks at trying to mitigate any unintended consequences, that is a recommendation that we can definitely provide within the report so that future measure developers take that into consideration. And then if there's also recommendations from this group to look at the other components that you have stated, and have the developer ensure that there is harmonization to the extent possible for those other components, whether it be tobacco use, other things like that. That is the point of this related and competing discussion, so that we can document those recommendations from this group so that the developer can go back to provide any further justification or assessment on whether or not they need to harmonize their measure even further.
I had one comment to make. I was thinking about what you guys are talking about, looking at untoward consequences. I don't want to incur a lot of burden for the developer, but maybe we could define certain clear clinical outcomes. So therefore, they would know, okay, you have a request for statins, give me your rate of, let's say, allergic reactions, things like that, and then you can track it, because it's easy for them to just say, oh, no, there are no untoward consequences. But if we ask them to include it in their data collection, that may give us an idea of, are we really causing more harm than good?
Yeah, it needs to be accounted for. Thank you for that. It needs to be accounted for in some ways. And again, latest data is that 30% of the population has an adverse event. And, so if we're saying that to be a good quality provider, you have to be able to meet this quality measure or offer this up as a measure that would suggest that you're a good quality provider, it seems to me to be negligent to not require some sort of complementary measure that ensures that people who choose this measure are actually doing the work to make sure that their patients are not part of the 30% of the population that has an adverse event. I mean, again, our knowledge about this stuff has evolved, and we need to take responsibility for ensuring that all of the elements of the knowledge and the evolution of our understanding of the impacts of these things are actually being included as we make attempts to define and enforce quality measures.
So I think that's great recommendations. And I know that we're sort of getting a little bit off the related to competing discussion. I want to kind of come back to that, but I think that this will be included in our meeting summary, as I think there's some clear concern around wanting to see some unintended consequences related to some of the components of the measure. I believe statin use was mentioned. So we'll capture that information. It'll be something that will be included in our meeting summary, included in the technical report. This is something I think the developer would be made aware of. But is there anything related to this discussion or related in competing that you would like to see the developer take a further look at?
Yeah. Again, I have no problem with a composite measure. I think it's very useful in terms of thinking about comprehensive care. I will just in the chat here put down a few of the measures I'm finding that may have some overlap with components of the composite. They're separate measures, different developer, don't have any problem with separate measures. But there are other measures other than just this one that they raised in their submission.
For the two that they did raise, however, I do think that the developers of the measure we've been discussing should not have to try to change their measure to try to harmonize it better with these two other measures. It would be better if those two measures, the developers of those two measures harmonize better with the measure we're discussing.
Why is that? I don't understand.
Because they define, when they do their search for people that they define as having diabetes, they use a medication database, medication claims database, and anyone who's on a medicine that's used to treat diabetes is included. But in the last 10 years, there's been an increasing use of some of these medications to treat pre-diabetes. And pre-diabetes is a very low, there are many more people with pre-diabetes than there are with diabetes. So this is that's a concern. So that a lot of the people who are being put into the denominator on these two measures, 61 and 59, really don't have diabetes. They have pre-diabetes.
So thanks for that.
But there are people taking metformin for anti-cancer, anti-aging. I mean, it's used a lot.
Well, that's another issue that makes the use of claims data, these medication claims data to define diabetes. It's just another issue as well. The EMR data doesn't do that. They basically look at the diagnosis.
So thanks for those comments. So I think I'm hearing that the current measure as it stands, James, based on your comments, maybe the other measures would need to have a look to see if there's some harmonization needs to be done to maybe meet this measure, which in that instance, we'd have to wait for those measures to come back through for endorsement. But part of what we ask developers to do is to take a look at other measures that currently are endorsed and to see how they can harmonize to those populations. So that may be something that they're taking into account when they bring this measure back through, which will be interesting to see if that is the case. Related to this measure specifically, and Dale, to your comments, is it fair to say that the committee is recommending that the developer take a look at the components and other NQF measures to see if there's harmonization efforts that have been made? And then if that's true, then we can definitely document that. And then if there's no other comments from there, we can continue to move forward. Thanks, Dale, for dropping in those measures into the chat.
There may be others. That's just ones I quickly found that are all diabetes related. So
thank you. And I don't want to, just overlook the unintended consequences comments. I think those have come through when we were actually evaluating this measure. It is something that we will capture within our meeting summary and technical report for the developer's consideration. And we would also see what comes through with public comment related to any of that as well. So appreciate those comments. Any other comments or recommendations related to this measure and other measures that?
Matt, this is Starlin. Do you think they would be also dredging for the CPT IC9 for the stat-induced myositis? Because it has its own. I mean, if I was pulling this data, I would include that on as a subset pool of everybody that was pulled in the initial. Does that make sense? That helps answer Ann's concern that if they looked for people that, like within their pool of people, there may be a subset of people that went to the doctor with muscle pain and got the liver enzymes pulled, but that might be something that we could send as a recommendation to address that unintended consequence.
I think that's a great suggestion. Although I would say if the physician has attributed it to statins and has identified that specific code, then they probably would then get added to the denominator, or they would be taken out of the population because they would identified as having an issue. Probably what would be most helpful in identifying ones who have issues that have not yet been identified as being linked to statins is to look at the list of adverse events that happen in the 30% of the population that have adverse events related to statin, and then look for the ICD-10 codes related to those symptoms, as opposed to the one code that specifically says this person has statin related.
It's a series of events. What you see in the data is you'll see they start them off slow and then move them up, and when they get to a certain level of high, if they need a high intensity statin, then they start exhibiting the side effects, then they back off. So you'll see people back off and do every other day just to mediate those side effects to make sure they can stay on the statin for good health. But and then you'll slowly see it just disappear off of their profile. But anyway, that's just something that we could maybe ask in their notes to look for that kind of stuff. I mean, we've come a long way from Anna, from when we first looked at all this, when we were all on the endocrine committee. Our data systems are so much more, actually almost too big, but so there is ways to pull that kind of data. So
yeah, and this
just
is
from my
really
experience.
good discussion on the unintended consequence. I want to note that, this unintended consequences piece we can definitely capture, but, that was something that we were reserving for the unintended consequences piece of when we evaluated for usability, which this committee had passed. So we will make sure to capture this information and some of the recommendations you had mentioned about looking in the data for certain CPT codes, Starlin, that you had mentioned, and some of the considerations you had mentioned as well, Anna. I think that that is something that we want to consider within the unintended consequences section of the usability component. just because that's evaluating if there is any unintended consequences with the use of the measure. So we'll capture that as a recommendation for the developer to consider. But again, just kind of circling back here on related and competing discussions and specifically related measures, outside of what Dale had recommended and looking at different components and different measures, was there anything else that the committee wanted to recommend for related and competing discussions? Okay.
The problem with the CPT codes to document things is that they're often not used. I mean, I see lots and lots of patients who have, have some muscle aches and muscle cramps, sometimes an elevated CPK, and I'll just switch them to another statin. But I don't actually document in the CPT code that they have statin-induced myositis. It's just because they've only been on it for a short time. You switch them to another statin that has fewer side effects, or you switch them to another drug that basically also lowers cholesterol.
Great comment. Thank you. Maybe something the developer has also considered when looking at unintended consequences, but as I stated, we'll make sure to document this in the report. But I think there were no other comments with related and competing, so I think Leanne will go to the next measure, and back to you.
Thank you, Matt. Okay, so we are going to move on to next slide, please, Victoria. So we have, next slide. So for 2797, that's the transcranial Doppler ultrasonography screening among children with sickle cell anemia. There were two related measures that were identified. 3166, antibiotic prophylaxis among children with sickle cell anemia, and 3595, hydroxyurea use among children with sickle cell anemia. Next slide, please. So here we have, excuse me, the measure description for 3166. So this shows the description of the measure, percentage of children ages 3 months to 5 years old with sickle cell anemia who are dispensed appropriate antibiotic prophylaxis for at least 300 days within the measurement year. And then the next slide, please. For 3595, this is the percentage of children ages 1 to 18 years with sickle cell anemia who are dispensed hydroxyurea for at least 300 days within the measurement year. So the measure developer said both measure denominators include children with sickle cell anemia within the measurement year. Measure 2797 is the number of children ages 2 through 15 years of age, whereas measure 3166 is the number of children ages 3 months to 5 years. For 3595, the children's ages range from 1 to 18 years of age with sickle cell anemia within the measurement year. And the developer notes that all measures have been harmonized to the extent possible. Next slide, please. So the three questions again are the measure specifications for the related measures harmonized to the extent possible, and are there any differences that could impact the interpretability and add data collection burden? So I will pause and open it up to the standing committee.
Yeah, so this is Dale. I looked at all three of these before. There's some overlap in the denominator depending on measure, but otherwise they're all three measuring different aspects of preventive care for kids with sickle cell anemia. And just knowing the huge cost to that particular disease, particularly in the Medicaid population, I really can't figure out why more people aren't holding more providers accountable for some of these measures.
Thank you for that, Dale. Anyone else from the standing committee have any feedback or recommendations for harmonization among those measures? Okay, I'm just going to check real quick for any raised hands in the participant list. Okay, next slide, please. So I'll just take a brief moment. We are at the part of our Measure Eval meeting where we are opening it up for NQF member and public comment. So I will provide a minute or two to see if anyone from the participant list will like to come off mute and provide their member and public comment at this time. Okay, hearing none, I will now hand it over to our manager, Isaac Seichi, who will, I'm sorry, we'll go through next steps. So next slide, please. I will hand it over to Tristan, who will go through our overview of the remaining activities and upcoming timelines for the project. So Tristan.
Thank you, Leanne. So following today's meeting, staff will prepare the draft report detailing the standing committee's discussion and recommendations. So this report will go and be released for a 30-day public and member comment period. Staff will then collect the comments and incorporate these into a comment brief, which will be shared with the standing committee as well as the developers. Following this, we will convene for our post-comment call when the standing committee will reconvene to discuss the comments received. Following this call, comments will be incorporated into the draft report to prepare for the CSAC meeting, and CSAC, the Consensus Standards Approval Committee. This is where they will meet to endorse measures. And then following this, there will be an opportunity for appeals. Next slide, please. So due to meeting all of our objectives today, we will be canceling the Measure Eval follow-up meeting. So we will not be having that on June 28th. The draft report comment period will be held from August 3rd to August 31st. And then CSAC review and appeals period is to be determined. So we will communicate those dates as those come out. And next slide, please. Here is our project contact info. If you are to have any questions, further comments, or concerns, you can email us or call us at the following number, along with the project page and committee SharePoint site. Next slide, please. I'll turn it back to Leanne for outstanding questions and conclusion. Thank you.
Thank you, Tristan. So I will open it up for any questions at this time.
I don't have questions, but I would say, I mean, you know, my mother happens to have issues with statins, and she's certainly not alone. But in terms of like what I was raising about the need for some sort of a companion measure to assess the adverse events associated with quality measures, when we know going into the endorsement of a measure that there will be adverse events for some members of the population. I think that's a broader issue that doesn't just apply to the statin measure, because we are learning and have learned that a certain percentage of the population has negative, has adverse events to lots of different medications. And there are probably others related to more processed measures. I don't know, but I think it's something that needs to be considered, because when you sit in these meetings, it's super easy, and I'm guilty of this as well, to overlook the real harm and the frustration and the life that adverse events or issues such as that cause in the life of individuals. And, you know, it's easy to think of them as a statistic or just a number that may or may not make its way into the denominator, but they're really needs to be careful consideration made for, if we're holding people to measures that are easy to check off, but not necessarily easy to follow up on and make sure that there is no harm caused. We need to give some serious consideration to steps that we can take to mitigate those concerns.
Absolutely. Thank you, Anna, for sharing that. And I definitely appreciate all your feedback and sharing that perspective. And I did write that down. We'll note that on our end. And I think I agree. I feel it's a very important consideration. We should be looking at the unintended consequences. And I do value also the perspective that you all bring to the conversations. And so I will definitely take this back. We have noted it, and I will make sure to get this into the final report. So thank you for providing that voice and providing that feedback during these calls. It is extremely valuable and very important.
Thank you.
Absolutely. Anyone else from the standing committee have any feedback or questions regarding the measure evaluation meeting or next steps? I'd be happy to answer.
I just want to thank all of you for all your work and support for all of us so that we can get through this. And we have technical error problems and email problems and life problems. And I also always want to thank Anna for bringing us to the reality of what our patients and the persons with diabetes or any sort of condition is going through. So thank you, Anna. And thank you, NQF, everybody. and of course the co-chairs. What would we do without our wonderful co-chairs that keep us in the boat? So thank you.
Absolutely. Well, that's a great headway to my next slide, which is wrap up. But I want to echo Starlin's appreciation. So I want to say thank you to the entire participant attendees today. Big shout out to the standing committee, our wonderful co-chairs. I know Adam had to also slip away at 2 for another commitment, but we have, definitely appreciate everyone's patience and their engagement and their participation. I know not too long ago we had a fall 21 measure evaluation meeting and post-comment meeting, so I definitely want to extend that appreciation to you all. I know a lot goes into the measure review and the pre-evaluation and the meeting, so thank you so much. I also want to thank our developers if they're on the line, but a big thank you to our developers for the time and effort leading up to the meeting and attending the call today to address any questions and concerns that the standing committee had. And then I also definitely want to thank my team, my entire team. So Isaac, Tristan, Tarun, Matt, Victoria, Matilda, Tristan, wonderful group that I enjoy working with every day, and they work very hard. So I want to definitely give them a thank you. So I hope everyone stays well, stays healthy, and stays safe. I hope the weather and the sun starts shining for you all. I know it's been a long day, so we are ahead of schedule, and so we can give you back that hour and a half day. So if you need anything, please let me know. Please email our project team. We're always here to assist you and support you. I'm going to leave. Oh, Dale, please provide your closing remarks. I'm so sorry.
No, great. Other than great committee to work with, enjoyed all the. I always learn so much from the committee, so really appreciate everybody participating.
All right, everyone. Thank you so much. Let us know if you need anything, and until then, please be safe and stay well. Thank you.
Thank you.
Thank you.
Thank you, Leanne.